Same time, I invite, welcome our past president, Dr. R. Palanisamy sir, who has joined today AMS program. Thank you, one and all.
Thank you. Welcome, sir. Dr. Palanisamy, sir. Thank you, our chairman, Dr. Rajesh Babu, sir. Now we call upon the state's AMS secretary for his welcome address. Dr. Jayaraman, sir, please.
Good afternoon, respected President W. Hassan, sir, our Honorary State Secretary Karthik Prabhu, sir, President-elect Dr. Sengutuvan, sir, and AMS Chairman Dr. Rajesh Babu, sir, and all the leaders of our IMA. I am very much thrilled to see the Coimbatore IMA is very vibrant. This is a centenary year they are going to celebrate. So wonderful activity. Coimbatore is always a role model branch to other branches. I congratulate Dr. Balamurugan sir, Chairman of Coimbatore IMA, AMS chapter, and Jalil sir, Secretary of the Coimbatore IMA AMS chapter, for the wonderful program. So today's program is West Zone IMA AMS Zonal Conference, so which will be organized in such a way that meticulously choosing the topics. I thank all the faculties, chairperson, and the speakers. The wonderful topic you have chosen, sir. So already Rajesh sir told clearly about that. We have a lot of AMS courses. Recently, we have approval. We got approval from the IMA headquarters for the sleep medima course. This 6 months course, both online and offline. And we have a Lepima Chennai too. That is in Chennai. We are going to start from Build-Up Hospital. I thank all of the leaders for this wonderful contribution, a wonderful platform to disseminate the knowledge across our Tamil Nadu. All our members benefit. So kind request everyone, those who are not joined specialty doctors, please join IMA AMS as a life member and enroll in FIAMS, fellow in that is association of our medical specialty FIAMS. So kind request to join all the programs. So stay tuned. We'll do a nice program. So I wish all these this program is a wonderful program. I wish the program for the grand success. Thank you very much for the opportunity. Thank you, sir.
Thank you, Jayaraman, sir. And I think we are ready to go for the scientific session now. And small instructions to the speakers. Each speaker have to talk for 15 minutes. Kindly do not exceed your time. And each session has got 2 speakers, 15 minutes. At the end of that, we can have a 10 minutes discussion. So each session has place for 40 minutes, 15, 10. So all the chairperson also, please kindly see that the session is not exceeded in time, so that there is some time left for the discussion on the particular topic. Now we straight away moving on to the first session. Always நம்ம குழந்தையா இருந்தா பெரியவங்களாவும் இல்லையா, எல்லாமே மழலையா இருந்து. அதனால always we start with we cherish our childhood. So here also we are starting the CME with the pediatrics topics. I invite Dr. Dorekannan sir, one of the senior most pediatrician, and our immediate past president of the Coimbatore IMA, very active member, as well as Dr. Balu sir, D. Balu sir from Atur, to chair the session and introduce the speakers and start the session, please. Over to you, sir.
Thank you, sir. Thank you, sir. And our vibrant State Secretary Karthik Prabhu sir, and my own State Chairman Rajesh Babu sir, and vibrant Secretary Jayaraman sir, and my Chairman Dr. Balamurugan, and the the branch President in absentia Priya Karthik, and Sri Ramalingam sir, Secretary. So at this juncture, I thank the opportunity for giving this AMS Coimbatore, and I must thank the state office bearers for granting this. Today's topic is the vaccination beyond childhood. You must be knowing that this vaccination is only meant for children. Most of the parents are aware that their child needs vaccination only up to 1 year or 2 years. After that, they either fail to report to the pediatrician or they stop doing this. But our IAP has defined the very characteristic cards, even the recent AHA conference at Nasik, they have introduced a very good,
Sir, your slides are not moving, sir.
very good, yes,
No.
sir, very good adolescent health card. So why the childhood vaccination beyond the childhood means the young population profile of India, it is alarming. It is 22% of the population they covered by adolescents. That is 253 millions. That is 12% belongs to 10 to 14 years and 10% belongs to 15 to 19 years. So every fifth person in India is an adolescent. Why you are concentrating on this adolescent? There is a global burden. You heard about the communicable disease, a non-communicable disease, which is the need of the hour, talk of the country, and 44.1% in children and adolescents, they are sustained to this communicable diseases. If you see the adolescent groups, there are three distinct disease groups are there. Like, for example, they are suffered from enteric infection, lower respiratory tract infection, and malaria. Malaria may be very less common in our area, whereas in northeast and northern states, it is very popular and very common. So the burden of what is called VPD, vaccine preventable disease in adolescent in India is rising. The studies indicate there is lack of protective antibodies in a significant proportion of adolescents. Because the purpose of giving the vaccines to the children, they produce a protective antibodies, and this antibodies in a course of time, they wane, they decrease in number. So of this, we are IAP fellows are concentrating on the vaccine coverage. The vaccine coverage in adolescent lags far behind that rate. And this coverage, especially in lower middle income group countries, they are much lower. See, in India, the tetanus and the diphtheria vaccine is the only recommended vaccine for adolescent in NIP, National Immunization Program, followed by Japanese C vaccine, which is offered in hyper-endemic area. In campaign mode still now, the measles MR is offered till 15 years of age. So you have plenty of re-emergence of these vaccine preventable diseases are coming. So we want to combat this re-emergence of this. So in IAP, we wanted to reintroduce the rubella, mumps, and the measles vaccine because of the recent outbreaks of mumps. Why adolescents need vaccines? Because the immune protection induced by vaccine given during the infancy, as I mentioned, wanes over a period of time. This leads to higher than expected incidence of EPDs in adolescents and young adults. That's the reason we are concentrating to vaccinate all these adolescents. So they need vaccination for the following reason. One, to protect against the disease that have higher morbidity in the adolescent age groups, especially the hepatitis and varicella. To boost the waning immune responses, those who already received the primary doses and thus antibody response will go down, we have to boost it. And these adolescents also need vaccine to prevent that appear later in adult life. The last one is those who are traveled abroad for study, they need to vaccinate themselves. So coming to the adolescent immunization schedule, these vaccine of adolescents are considered under 4 groups. Exclusive adolescent. This is exclusive adolescent vaccine means this vaccine, they should take it at least. Even if their primary doses they have taken, they have to take this vaccine. Those who have missed some of the vaccine, they can go for catch-up vaccine. Then the third one, vaccine for adolescent in special situation. And finally, the vaccine for adolescent travelers. This is the last one we usually come across. Those who want to travel for studies, they need, according to the country, they need some vaccines. So what is exclusive adolescent vaccine? In respect of the vaccine status of the children or their childhood age, they have to take this tetanus, diphtheria, pertussis, and human papilloma virus. This is mandatory for all the adolescents. Remember, this is tetanus, diphtheria, pertussis, HPV is mandatory. All the adolescents, they have to take this. Those who missed some of the vaccines in the childhood period, these are all the vaccines they have to take it. We call it as a catch-up vaccines: measles, mumps, rubella, hepatitis A and B, varicella, and typhoid. These are all the vaccines. If they missed in the childhood, they can take it during the adolescent age group. The vaccines for special situation, like in seasons like influenza season, pneumococcal vaccine, Japanese encephalitis in hyperendemic area, and rabies and meningococcal. These are all some of the special situations they have to take it. And this is very important because most of them, after their school, they travel for abroad study, further study. They have to take this meningococcal. Those who are traveling to African country, they have to take the yellow fever, Japanese vaccines, and rabies if they have the exposure. So these are all, in short, the recommended vaccine for adolescent with the prioritization. That is, one is, it is mandatory, as I mentioned, either TD or Tdap, and HPV, which is again the cervical cancer. We recommend the Tdap for because of the more immunogenicity and more the antibody response. We always suggest Tdap instead of TD. Then you have the catch-up if they missed during the younger age group, like MMR, varicella, hepatitis A, hepatitis B, and typhoid. The high risk, that is special situation, or some high risk adolescent, in a seasonal way, they have to take the influenza, meningococcal, Japanese, pneumococcal, rabies, and yellow fever. Sometimes in periods like cholera season, cholera vaccine. So this is in short the routine immunization recommendation. Adolescents 11 to 18 years, single dose of Tdap at 11 to 12 years, followed by one booster dose, either TD, preferably Tdap, every 10 years throughout the life. Remember, you have to take every 10 years throughout the life. If you are above 19 years, they never received Tdap, should get at least one dose of Tdap, regardless of the interval, since the last tetanus or diphtheria toxoid containing vaccine, followed by booster, either TD or Tdap. As you all know, in the NIP, pregnant women, one dose of Tdap during each pregnancy. Now, instead of TT, we go to Tdap because of the cocooning effect for the prevention of pertussis for the newborn. Another one is the wound management. The TT usually we give, which containing vaccine if more than 5 years have passed since the last TT containing vaccine in case of contaminated wound, and once in 10 years in case of a clean wound. This has to be mentioned, human papilloma virus. This deserves special mention because this HPV infection is the most common sexually transmitted infection in humans. This is associated with urogenital and oropharyngeal cancer. And remember, this is the only vaccine available for the prevention of cancer in humans. There are 3 vaccines we come across: bivalent, quadrivalent, and monovalent. The bivalent is withdrawal from the market. We have quadrivalent and monovalent. These are all the types we have available in the commercial market. So every kids or every boys and girls and adolescents, they should have the HPV vaccination in order to prevent cancer prevention. This is our angel protection IAP. We have a separate module for that. So this suggests protect your daughters in future to get the HPV vaccine. So this is the chart we have to take it. Cervical cancer under 14 years, above and 15 and above 3 doses. This is the schedule which is available, and you have to take hepatitis B 3 doses, A 2 doses, and MMR, varicella, typhoid, influenza 1 dose every year. Remember, the starting dose of influenza is 2 doses we give in 6 to 7 months, and this has to be followed as a single dose every year. A point for elders, after this elder people, they also need the pneumococcal vaccine and influenza. Pneumococcal is a start dose, and influenza yearly we have to take it. In a special situation, we considered the immunization in immunocompromised, where the live vaccines is contraindicated, children infected with HIV, those on corticosteroid and other immunosuppressants we have to modify, All these conditions, live vaccines is contraindicated, and cancer cases which are who are all on chemotherapy and radiotherapy, transplant recipient, and congenital immunodeficiency, chronic diseases, and all these, they have a modified course of a vaccination. This is a latest growth card. This is Kishore Mitra card, which is released in IABAHA in the recent conference. Every practicing pediatrician or practicing physician, they can download from the website. They should have this card in order to give a very prompt and better care for the adolescent age group. So this is mentioned birth history, developmental history, menstrual history, post-medical, family, and all this, and we easily mention this, including the SMR, visual hearing, all can be monitored and documented as a routine health card. This is an adolescent health card. This is again the immunization card for the adolescent, and you can follow that. And it has depicted the helpline for the cybercrime, child abuse, everything. You can have that in your desktop table and verify. This is the final slide of this. Yeah, this is anticipated guidance. This is one of the very important aspects of any pediatrician. There is do's and don'ts. What are all the do's? Love and care for oneself. Eat balanced, healthy food thrice a day. Sleep 8 hours every night. Run, cycle, swim, or play for 1 hour daily. Learn and implement study skills. Use social media safely. Respect differences. Be alert and sense danger. Report physical, mental, sexual abuse. These are all, you have to tell all the growing kids and adolescents, these are all the do's. What you should not do, don'ts. This is very important in our daily, day-to-day practice. The anticipated guidance has to be communicated. One, neglect stress. Don't have any stress on your act impulsively before you think. Hide physical or mental troubles. Succumb to wrong pressures. Report to addictive substances. Disregard traffic rules. Throw tantrums. Bully or get bullied. Abuse or get abused. So this is with this I finish my talk on childhood vaccination beyond delay. Thank you for patient listening. Thank you.
Thank you, Jalil, for an excellent deliberations as a pediatrician. But we need beyond pediatrics, pediatric age group, we need a certain vaccination that has to be done. That is cervical cancer vaccination. The WHO has earmarked 2030 to eliminate cervical cancer. So we will, from IMA side, we'll take it as a project that all vaccination, all school-going students or college-going students should be vaccinated. Even we got a cervical vaccine for the married people also. Once a year they have to do it. And another is beyond pediatrics is the pneumococcal vaccine. At the age of 60, anybody who is crossing 60 or they got any comorbid condition, they have to take pneumococcal vaccine. Twice, one is the pneumococcal 13 and another is a polysaccharide vaccine after that. There is a nice book written by Dr. Muruganathan, Adult Vaccination also. It is published and it was IMA book also. So beyond pediatrics, beyond childhood, there is vaccination till it is 85 years. So thank you for your excellent presentation, sir. Thank you very much.
Thank you, sir.
Over to Dr. Balu. Balu is there? Balu?
Sir, you can call the next speaker.
Right. May I call Dr. Neminathan, the excellent academician and always thirst for teaching. May I call Dr. Neminathan. He is going to talk about antibiotics. In India, there is more than 38% of the people are using antibiotic. Every prescription there is antibiotic. So how to use the antibiotic, how judicially we have to use our Neminathan will explain to you. Neminathan, sir, over to sir.
Thank you very much, sir. At the outset, I'd like to thank Dr. Balamurugan sir, Jalil sir, Rajesh Babu sir, Jayaraman sir, Abulasan sir, Karthik Prabhu, Sengutuvan sir, and Dr. Duraikannan and Balu sir for inviting me to talk on this important topic. Friends, I'm sure all of you will agree with me. Vast majority of the febrile illnesses in children are viral in nature and they do not require antibiotics, as rightly told by my senior Dr. Jalil sir and Dr. Duraikannan sir. Because in our day-to-day practice, particularly during this monsoon season, every febrile child receives an antibiotic. So antibiotic is the most commonly used drug. At the same time, it is the most commonly abused drug also. So what does stewardship mean? It is choosing the right antibiotic, which is an art. It consists of 5 right things that you need to do. First thing is you must make a right diagnosis. After having made a diagnosis, whether it is viral or bacterial, if it is going to be bacterial, you have to do these 5 things. One is you have to choose the right drug and use the right dose and use it at the right time for the right duration. And once you know it is viral, you must know to de-escalate. That's called last D. So
Neminathan, you share your slides, Neminathan. Your
Yes,
slides
sir,
are
I'm
not.
sharing. Can you see me, sir? Can you see the slides?
No.
Slides are not moving, Neminathan.
No, he has not gone to the next slide, I think. Yeah. Yeah. Can you see the sir? Yeah.
$1 million question, just in there.
Only is come to
So-
the $1 million. Yeah. So the $1 million question is that whenever you see a child who comes to your OP with a fever, so whether is he having a viral fever or a bacterial fever? This is a 5-point rule which we need to apply in our day-to-day practice. If you apply these 5 points, you can come to a reasonable diagnosis. This 5-point rule has got a sensitivity and specificity of nearly 99%. So, well child who was playing well suddenly gets a high-grade fever, which means it's a viral fever. You can ask me why not bacteria? Bacterial fevers have got a long incubation period, 5 days, 7 days. Whereas viruses like flu, only hours, 2 hours. So at 8 o'clock, child is already 10 o'clock, 1 or 2 degree fever. It is viral fever. Particularly during this monsoon season, it's a flu fever. If there are more than one member in the family having fever at the same time, it's a viral fever because of the ultra short incubation period. There are more than one site that is involved. For example, running nose, red eyes, congested throat, along with fever, it's probably viral. Multiple sites involvement is viral. And multiple system, the mother says, என்னமா பண்ணுதுன்னு கேக்குறீங்க? The mother says, சார் வயித்தால போகுது, வாந்தி இருக்குது, உடம்பெல்லாம் பொறிப்பொறியா இருக்கு, இருமல் இருக்குது, கைகாலெல்லாம் குடையுது, சாப்பிட மாட்டேங்குது, சோர்ந்து போகுது, மூச்சு விட சிரமப்படுது. If she says, that's called a verbal diarrhea. The mother says, multiple system is involved. On auscultation, you find a bronchi and rolls on both bases, and there is an acute viral diarrhea suggestive of small gut involvement with a skin rash and joint involvement. It swings the pendulum towards virus. And the fifth important point is that during the interfebrile period, between 2 spikes of fever, if the child is up and about playing, probably it swings the pendulum towards viral. Whereas in bacterial, because of the tissue hypoxemia, fever will come down, but the child will remain dull. So if the 5 point is, if you apply this 5 point for every febrile child, you can reasonably come to a diagnosis whether it is a simple viral fever or a bacterial illness. Having applied this rule, just give paracetamol, send the child back home, educate the mother about the danger signs. Vast majority of the fever will settle down by around 3 to 5 days just with paracetamol. In that case, your diagnosis of short pyrexia, nil localizing, probably viral is confirmed. So, as I once again tell you, vast majority of these seasonal illnesses are viral in nature. 90% of the fevers do not require antibiotics. With this introduction, let me go to the next important slide. Here you have a child who was bitten by a stray dog while playing. this is automatically you can make a diagnosis. It's a category 3 bite. Suppose as rabies, you know how to manage, wash with water and give ARB and anti-rabies immunoglobulin. The question is, coming to this talk, what antibiotic are you going to use in this child? I'm sure animal bite, these organisms, multiple organisms are there in the oral cavity of the rabid animal or a non-rabid animal beyond rabies. So these are the common organisms that we see in our day-to-day practice, particularly in dogs and cats. Nearly around 15 organisms are there. Majority of them are aerobes and some of them are anaerobe. And the commonest aerobe is the Streptococcus and Staphylococcus seen in most of the dogs and cats. So these 15 organisms are amenable to a single antibiotic that is called amoxicillin. So in your outpatient practice, when you have an animal bite, the safest antibiotic is amoxicillin. If it is a category 1 bite in a dog bite, topical antibiotic is more than sufficient than an oral antibiotic. So at the same time, when you compare a human bite, nowadays we do see lots of the school opening time, we see lots of children being bitten by children. So in human bite, if you look at the organisms from the textbook of pediatric infectious disease, Finn and Cherry, there are more than around 50 organisms, nearly 4 times that of the organisms in the animal's mouth. So these are polymicrobial. The commonest is alpha hemolytic streptococcus. And you do have lots of aerobes, anaerobes, gram positive, gram negative, and sometimes ESBL producing organisms, including a common organism that's called Econola cordens. And once again, the antibiotic choice is amoxicillin. Please remember, these antibiotics have to be given for a period of 5 to 7 days. The next commonest thing that we see in our day-to-day practice is UTI. Commonly, whenever you find a child with older child, particularly with dysuria or a painful urination with voiding dysfunction, constipation, think of UTI, do a urine microscopy and take a urine culture. This particular child showed Citrobacter grown in culture more than 10 to the power 5 colony flocculation units per ml. That is, this is a definite bacteriuria consisting of an organism Citrobacter. So the commonest organism that we see in pediatric UTI is called E. coli. So when you have a E. coli, it's called a simple UTI. If E. coli is not there, any other organism other than E. coli like Klebsiella, Proteus, Citrobacter, then it becomes a complicated UTI. The important thing what we should know is complicated UTI, these organisms are either beta-lactam producing organisms or AMC producing organisms. So particularly this Citrobacter is an AMC producing organism, is resistant to all your conventional antibiotics like your amoxicillin, ampicillin, sulbactam, piperacillin, tazobactam, even cefoxitim and ceftazidime and ceftriaxone. When you have a child with Citrobacter, you need to go for antibiotics that cover escape-M organisms. They are called Enterobacter, Serratia, Citrobacter, Aeromonas, Proteus, Providentia, and Morganella. Though this is rare, as practitioners, we must remember these escape organisms. When you see such a child, the antibiotic of choice in an outpatient setting in a well child is cotrimoxazole. In an inpatient setting or as an outpatient, those who are staying nearby can come for an IM injection once a day is amikacin. So please remember these 2 organisms. Suppose if many of these children, before taking culture, we start them routinely on cefixime. When you see any organism that belongs to this HESCAM, you have to switch over to either cotrimoxazole or to amikacin. For example, if the child is sick, child has got symptoms of upper UTI, then you need to consider pyelonephritis. Always they need IV antibiotics in the form of amikacin. So cotrimoxazole is an orphan antibiotic. Many of us have stopped using this cotrimoxazole. Now once again it has come back to the surface where we can use it safely in many of the salmonella infections. Many of the typhoid cases which are resistant to conventional fluoroquinolones or sensitive to cotrimoxazole, you can safely use it. So only thing is when you use cotrimoxazole for a longer duration, please keep pancytopenia, dyslipidemia in the back of the mind. Always when you prescribe drugs like Septron or Bactrim, tell them there is a skin lesion, mucocutaneous lesion or oral mucositis. They have to come back immediately. You need to stop the drug and then consider Stephen Johnson in the back of the mind. So having seen cotrimoxazole, I told you about aminoglycoside, that is amikacin, as the best drug, particularly when you have a complicated UTI, non-E. coli UTI in an outpatient setting, is amikacin, because this is a drug which is a concentration dependent drug. When you give it a concentration of 15 milligram per kg weight, it has got a rapid killing. Even the organisms that are resistant or killed with a higher concentration. Another good thing about this drug, particularly amikacin and aminoglycoside and azithromycin, is that both of these two drugs has got post-antibiotic effect. Even if the MIC falls below, the antibiotic level falls below MIC, the bactericidal action persists. That's a good thing about any antibiotic. So, having seen this, whenever you use amikacin for a longer duration, more than 5 days, please keep ototoxicity and nephrotoxicity in the back of the mind. And never give gentamicin ear drops for a child with a discharge, because it can cause direct ototoxicity. Here you have a child with conjunctivitis and otitis media. Sometimes, particularly during this monsoon time, we do see children with conjunctivitis and otitis media, ear pain and a purulent discharge from the eyes. So in such a situation, the commonest organism that we encounter during monsoon is adenovirus. Please keep this in the back of the mind. 90% of the viral conjunctivitis are caused by adenovirus, and they do not require antibiotics. And the common bacteria that we see in our OP practice, particularly nowadays in non-vaccinated children, is non-typable H. influenza. And if it is a unilateral conjunctivitis, it's atypical organism Moraxella catarrhalis. Bilateral with lid edema, think of Streptococcus pneumonia. If you have a neonate with conjunctivitis, always keep gonorrhea in the back of the mind. So how to differentiate clinically between viral and bacterial? That's very, very important. Suppose there is a purulent discharge and the eye is red in color with no pre-auricular lymphadenopathy, it is a bacterial conjunctivitis. The child will require oral antibiotics. Otherwise, if the child has got an itching or a gritty feeling in the eye with pre-auricular lymphadenopathy, most of the time bilateral, it is viral in nature, they do not require oral antibiotics or topical antibiotics. Please remember, eye drops are the commonly used, misused drug in our day-to-day practice. So whenever you see a child with conjunctivitis, there is no pre-auricular adenitis, do not prescribe antibiotic eye drops. Because many times viral conjunctivitis, they go home with an antibiotic. So please keep that in the back of the mind. Now you have a child with a small abscess in the right cubital fossa, which is less than 5 centimeters in size. When you have an abscess of less than 5 centimeters in size, the first thing you must think is what could be the organism. The commonest organism is Staphylococcus, followed by Streptococcus. The antibiotic of choice is amoxicillin. Particularly selecting the antibiotics only by looking at the size of the abscess. Commonly what we see is irrespective of the size, we prescribe antibiotic. Very, very important message I'm going to give you. This is by the Infectious Disease Society of America, which says in children, an abscess less than 5 centimeters needs only INT. No need for antibiotics, oral or IV antibiotics. If it is more than 5 centimeters, or there is a severe extensive disease with progression to cellulitis with systemic symptoms, or in a child with comorbidities like on steroids, or the abscess is difficult to drain sites like face and genitalia, you can use antibiotics. Otherwise, routinely in any abscess which is less than 5 centimeters, just INT is sufficient, even in methicillin resistant Staphylococcus aureus. That's an important message which I told you today. So this is another child who has got a sandpaper rash with a pain in the throat. On examination, you see enlarged erythematous tonsil with palatal petechiae. Rapid antigen test for Streptococcus is positive. The diagnosis is scarlet fever. We had incidents of scarlet fever a couple of months back throughout the country. The drug of choice is amoxicillin. They do not require clavulanic acid because you need to use only amoxicillin, and preferably amoxicillin has to be given for a period of 7 to 10 days. Particularly when you have a patient who comes to your OPD with fever with rash, you have to ask this question: when did the rash appear? If the rash appears on day 1, it's probably varicella. Day 2, scarlet fever. Smallpox is eradicated day 3. Measles usually on 4th day, 5th day. It's called Anjampani in Malayalam. Typhus you get on the 5th day, dengue on 6th day, and typhoid you get it on the 7th day. By appearance of the rash, you can remember these mnemonics called very sick patients must take double tablets. By appearance of the rash, we can delineate whether this child needs antibiotic or not. Only among these 7 diseases, only 3 needs antibiotic. Rest of them do not need antibiotic. So let's come to a very important case that we see in your day-to-day practice, which is a bacillus dysentery. Whenever you have a bacillus dysentery, the organism is either Shigella or E. coli. Rarely you do get Salmonella, Campylobacter, or Yersinia. The commonest is Shigella. The Shigella is an organism that has got 80% resistance, particularly in a study done in the Institute of Child Health, Kolkata. And they have got 100% resistance to nalgesic acid, cotrimoxazole, norfloxacin, and ciprofloxacin. So never use these drugs, norfloxacin, ciprofloxacin, for a bacterial dysentery in children. So the antibiotic choice in our day-to-day practice is cefixime, and other antibiotic choice of azithromycin. And rarely you can use cotrimoxazole. So the dose of azithromycin is 12 mg per kg on day 1, followed by 6 mg per kg for 4 consecutive days. And cefixime in a dysentery is 8 mg per kg per day, whereas in enteric fever, as I told you earlier, it is 20 mg per kg. If the child is sick with dysentery, you can admit the child, start the child ceftriaxone 50 mg per kg. So last few slides, 3 slides. Coming
Just
to
running short of time, sir. Can
Yes,
you just
sir.
conclude? Yeah.
Last 3 slides. Carbapenem should not be used in our day-to-day practice. And when you see a CBC, if you have a eosinopenia, it swings the pendulum towards enteric fever. There is eosinophilia cytosis, it swings the pendulum towards malaria. If there is a hematocrit elevated with a thrombocytopenia, it swings the pendulum towards dengue. And the last slide, if you have a child with supradiaphragmatic infection, gram-positive infection, amoxicillin, infradiaphragmatic infection, gut and urinary tract infection, gram-negative infection, cefixime, skin and soft tissue, first generation cephalosporin, cephalexin, or cephaloxil, that is second generation cephalosporin. Only 3 antibiotics. Thank you. Thank you. There are questions.
Thank you,
that
Neminathan.
answer.
Thank you, Dr. Neminathan. Excellently explained. நோய் நாடி நோய் முதல் நாடி அது தனிப்ப வாய் நாடி வாய்ப்பை செயல்னு நம்ம திருவள்ளுவர் சொல்லியிருக்காரு. அதே போல
kindly mute, please. Yeah, the delegates who are not talking, kindly mute, please.
yes, as our Neminathan sir explained, there is WHO classified antibiotic into 3 groups. One is a watch group, and the second is access group, and third is a reverse group. Watch group is for the severe infection, we can give certain type of antibiotics. Access group, we can give to the infection mild, that will not produce the minimum resistance. Reverse group only for the life-threatening diseases. So we have to categorize, then only we will put in for a few seconds, we have to take whether you are giving bactericidal or bacteriostatic. Bactericidal means we are killing the bacteria. Bacteriostatic means we are reducing the spread of the disease and the growth in the cells. So to clear the infection, so better always get opinion for even ophthalmology or skin diseases. If it goes beyond a day or two, it's better get the opinion of the eye specialist. And drug abuse is more in the viral fever. We should classify what is viral fever, what is classified fever, as said by our name in other. Nowadays, azithromycin is mostly used for a common cold, and the cardiac medicines also totally abused. Once they get a prescription, they're taking also, they're advising the neighbors also. And macrolide, as usual, it produced Stephen Johnson syndrome. It should be keep in mind before prescription. So thank you, Nemina, for
Very
your
good,
excellent
sir.
and a
We have a
pediatrics.
couple of
Beyond pediatrics, antibiotic should be used in a judicial way. Thank
sir,
you.
we have a
Thank you,
couple of
sir.
we have a couple of questions, sir. And
Right.
one question Dr. Sundaramurthy has asked: ideal period for HPV for girl babies. And
Ideal period is
yeah,
Sir,
we lost the
can I
speaker, sir.
ask, sir? Can
it
I?
is
Yeah,
nine.
yourself, sir. Dr. Jalil, sir, you will answer.
Jalil will explain.
Yeah.
Sir,
And,
HPV is 9 years onwards, 9 to 14 years, we have to take 2 doses now. So
Yes, sir.
the earlier, the best, more the number of antibodies production, and best the protection against the cervical cancer. It starts
Yeah,
from 9 years for
one
boys
other
and
doctor,
girls.
one other doctor has asked, Dr. Anand has asked that he's somebody 29 years old and whether, only 1 second, sir. 1 second. I'm 29 years old. I didn't take any HPV vaccine. Now, can I take HPV vaccine?
Yes, sir, because this is after 25 years, you have to subject them for the screening. If the screening is negative for HPV, that is the cancer cells, they can take the 3 doses of HPV
they-
vaccine.
Yeah, one
After
Dr. Angarajan
screening.
Dr. Angarajan sir has asked a question that is yellow fever vaccination advised? Is it available?
Sir, day before yesterday, I vaccinated one baby. It is not available anywhere in Chennai and Cochin. You have to go to the Port Trust Hospital, Cochin, in prior appointment. Those who are traveling to Africa, especially the Kenya and all, they have to take the yellow fever, which is mandatory. It is available in Cochin, Port Trust Hospital.
Yeah, thank you, Dr. Jalil sir. And regarding the antibiotic, we have a couple of questions. One, Dr. Sundaramurthy has asked any role for olden day antibiotics in present practice. Dr. Neminathan sir.
Yes, sir. It's a very good question, sir. Olden days antibiotics like cotrimoxazole, your chloramphenicol, they are all called orphan antibiotics. They are all good antibiotics that has been extensively used by senior practitioners. Now we have forgotten them. Now they are coming to limelight once again. Because as I told you, by the lots of studies in various parts of the globe shows that many of the diseases like Salmonella, Shigella, there are extensive resistance to misuse drugs like fluoroquinolones, even azithromycin resistance is very high. So these drugs, these organisms are sensitive to your chloramphenicol and cotrimoxazole. So they are a very good drug for the re-emerging diseases.
How common is scrub typhus in India in pediatric practice?
Of course, we do see lots of course, we do see lots of scrub typhus in the back in our country, sir, particularly during monsoon. So we have to keep that in the back of the mind. Whenever you see a child with a fever, with a rash, with the involvement of the palm and soles, with spotted fevers, you have to take a history of having gone to the wild, having gone to the forest, or having gone to falls. The history is very, very important. You have to thoroughly undress the child, see from head to foot, particularly in hidden areas like axilla, behind the ears, behind the scrotum, the intergluteal region. Many times, 70% of these cases, you can pick up a Escher, which confirms the diagnosis. And the good thing about this is a single dose of doxycycline or azithromycin will rapidly reduce the illness. On a short course, 5 to 7 days, you can completely reduce the severity, mortality, morbidity of this really fatal illness. Because last week we had a child with 15 days of fever. A nurse's child came from Urmulpet. The child went to Tirumurti Falls 3 weeks earlier. 7 days later, child developed fever, received multiple antibiotics. And then when undressed the child and we could see an issue in the gluteal region. Just making the child undress, giving a single dose as outpatient. We treated the child with 15 days fever with a single dose. Next day, child became all right.
Thank you, sir. And finally, your comment on the
Neminathan,
protecting the... Yes, sir. Once
Neminathan,
again,
one
sir.
correction. This
Yes,
is
sir.
the doxycycline single dose. We have to complete the course for minimum 5 to 7 days.
No, the actually what I want to mention is single dose will reduce the fever, bring down the 15 days fever. The course is 5 to 7 days. Course
That
is
we
5 to
have to
7
tell
days.
to the parents.
Yeah. Because
No.
many a times they are worried about the fever. So you can just, if you make a correct diagnosis, they'll be happy just with just the fever will come down. But the course, as you rightly said, you need to complete the course of 5 to 7 days.
Sir, a few of our colleagues have asked that, how do we protect the bowel commensals while we start on broad spectrum antibiotics in pediatric practice?
Excellent, sir. Excellent, sir. Sir, can I ask a question to Dr. Dorekanan, sir?
Tell me, sir.
Sir, what is your weight, sir?
My is 70.
70?
70.
Actually, telling the fact, Dr. Dorekanan, sir, weight is only 68, sir. 2 kilos of your weight is contributed by the commensals in your gut. So
I see.
microflora in your
Yeah.
gut is 2 kilos and your weight is
Yes.
only 68, sir. So
Right.
everybody, all the doctors who are attending this conference have got 2 kilos of this microflora in our gut. But one bad thing about this antibiotic, misuse of antibiotics will destroy all these gut flora, that is microbiomes in our gut. So these beneficial bacteria will be destroyed by misusing the antibiotics. So first thing is prescribe antibiotics only if you make a diagnosis of bacterial illness. Do not prescribe antibiotic for viral illness, number one. If at all you prescribe an antibiotic, if you prescribe for a short course, the right dose, right duration, most probably it will not have a deleterious effect. Misuse of antibiotics are the ones that causes. So every antibiotic do not require a probiotic along with antibiotic prescription. And if you want to give a probiotic, you need to give the probiotic after consumption of 2 hours after the antibiotic, not along with the antibiotic. The best antibiotic recommended by the pediatric used by the task force on pediatric gastroenterology are number 1, Lactobacillus rhamnosus GG, and the another one is Saccharomyces boulardii. All other probiotics are not that used in pediatrics. And always, whenever you give a probiotic, please give prebiotic diet. Prebiotic diet is breast milk, curd, buttermilk, and bananas. These are all prebiotic diets. This has to be given to enhance the growth of the probiotic.
Yeah.
And the most important message is 90% of pediatric fevers do not require antibiotic.
Thank you, sir. Thank you, Dr. Neminathan, sir, Jalil, sir, and Dr. Dorekanan, sir, for excellently chairing and moderating the session. And probably as we're running short of time, we'll move on to the next session, sir. And the cardiometabolic diabetics division talk. And may I invite Dr. Venko Jayaprasad. He is a professor of diabetology, Coimbatore Medical College, and one of the senior and a young and active energetic diabetologist, academically interested, to chair the session and further proceedings, please. Over to you, sir. Dr. Venko.
Thank you, sir. Very good evening to one and all. It's an amazing opportunity to be with the IMA Coimbatore in this session. And now, after this whirlwind session on pediatrics and all the comprehensive management of fevers wonderfully done by Dr. Neminathan, we have another sessions on diabetes, again going to be by 2 prominent speakers, Dr. Balamurugan sir and Dr. Pavadarni madam. First session will be answering the $1 million question, whether my diabetes can be reversed or not. So many people, it's not only a $1 million question, but many people are making millions out of it. So is it really the truth that diabetes can be reversed or not? Or is there some other term for it? Or is it a myth? Does it come with some catch? For this to be answered, we have Dr. Balamurugan sir. We need not introduce Dr. Balamurugan sir, the most prominent diabetologist of Coimbatore. And because of the lack of time, I right away invite you, sir, to go ahead with your wonderful talk.
Yeah, thank you, Dr. Venko, for nice introduction, and thank you for all the scientific committee of this conference for this opportunity today. And so, as I already said, diabetes reversal, a myth or reality, we will see now. So, reversal of diabetes, what is it? Reversal, remission, or cure? I do not have any conflict of interest for this talk, and one of the example, common example being the honeymoon phase of.
Sir, வணக்கம் சார். நல்லா இருக்கீங்களா?
Sir, Jalil sir, can you mute please? Honeymoon phase of the type 1 diabetes, which is actually remission. Generally, initial period you might get where there is a minimal, say, after control, there is a minimal residual beta cell function, and this is the honeymoon phase. We call it a remission in type 1 diabetes. So, what are the other known remissions? Type 2 diabetes, we see it following the bariatric surgery, the glucotoxicity, especially the newly detected diabetes have A1C less than 9%, stress hyperglycemia, and infections. Again, what happens to the diabetes remission after bariatric surgery? What is the mechanism? You look at the gut. What is the gut physiology which is getting altered? That's the reduction in the calorie intake, increased jejunal nutrient sensing, and increased intestinal gluconeogenesis. On the other hand, you look at the metabolic consequences of that. There is increased hepatic insulin sensitivity and decreased hepatic glucose production. On the other hand, whenever there is an increased postprandial glucose GLP-1 secretion, this will have an effect on the pancreatic beta cell to improve the beta cell function. And again, there can be alternate systemic factors like reduction in the anti-incretin factors, increased GLP-1 and POI. On the other hand, there's increased glucose utilization also in addition to the altered gut microbiota. Again, which can, again, looking at the muscle, there can be increased peripheral insulin sensitivity, which can be caused by reduction in the body weight, reduction in the anti-incretin factors, and increased bile acid pool. These are various mechanisms by which diabetes remission can occur following bariatric surgery. Second case of remission is reversing the glucotoxicity. There have been various studies. One of the 5 studies, Ilkova et al., Lee et al., Weng et al., and Chen et al., almost, they have trying to reverse the glucotoxicity by insulin. And mostly newly diagnosed type 2 diabetic patients, and they used continuous subcutaneous insulin injections, or sometimes they try to use multiple daily insulin injections. Almost they did it for a 2 weeks period, and they followed up for a 6 months, 2 years, and 1 year period. You can see the results. Their endpoints were fasting less than 7.8 or 7 millimoles, and 6.1 different one. And you can look at the outcome. Almost the remission rates were around 40 to 69%. And this data was published in Diabetes Care in 2008. And this was an interesting study. It was published in the Global Report on Diabetes in 2016, the WHO report. In Barbados, it was done, reversing the type of diabetes in Barbados. Barbados is a 19% prevalence of diabetes among adults. 1 in 3 of them are obese. 2 out of the 3 are overweight obese. In this, there is a Barbados diabetes reversal study designed to test the feasibility of a 8-week low-calorie diet with a follow-up support for 6 months on diet and physical activity to reverse type 2 diabetes. Here you can see almost these many people in this thing, whenever they try to lose weight following this diet, this diabetes is reversed. I just want to tell you, by any methods, if you are able to reduce the weight, your diabetes undergoes remission. And see, this is, look at the liver. So on the one hand, you can see the normal liver where the fat content is less. On the other hand, you can see the liver in type 2 diabetes where there's a increased fat content. Okay, in the liver there's insulin resistance. Okay, and this is an MRI study of the liver. So whenever you are able to reduce the fat content, general obesity, body weight, the fatty liver content, the fat content in the liver also comes down again. And this is the counterpoint study where they try to reverse the type 2 diabetes by normalizing the beta cell function. So by reducing the weight, and you can see the the fasting plasma glucose level, again, and the basal hepatic glucose output and the hepatic triglyceride, all comes almost is an 8 weeks data, which is known. There is the normal, which shows that there's a normalization of the beta cell function. This data was again published in the Diabetology. This counterpoint study data, she studied the beta cell function also, where and pancreatic triglyceride content, again the first phase of insulin secretion. There's improvement in the first phase of insulin secretion, reduction in the pancreatic triglyceride content. This is a very, very important study called direct trial, where they try to look into whether the reversal of diabetes is possible. They basically know they have a hypothesis that excess fat in the liver and the pancreas. So drastic loss of weight reduces the fat in the pancreas and helps to limit the disease. That's what that hypothesis. This was detected from a study conducted between July 25, 2014 and August 5, 2017 among 298 people aged between 20 and 65 and diagnosed with disease in the past 6 years. So 149 were put on weight management program, anti-diabetic and blood pressure lowering medication were all stopped at the start of it. The rest continued with the best practice care, including medication. So this is a 3-step program. Step 1, the low calorie formula diet. They gave approximately 825 to 850 calories for 3 to 5 months. The second step 2, they stepped for food introduction, the 2 to 8 weeks. Then step 3, ongoing support for weight loss maintenance with strategies to increase the physical activity. What was the result? A year later, 46% of the participants who lost weight significantly did not have diabetes. The highest in those were who lost over 15 kilos. And this is called a direct trial. Primary care led weight management for remission type 2 diabetes. This is called direct trial. So now open label cluster randomized trial. Here also you can see the proportion of patients achieving a 15 kg, more than 15 kg weight loss. Okay, when compared to the control group, it's a 24% in the intervention group. Again, looking at the proportion of patients achieving remission at 12 months, it's almost 46% in the intervention group. And look at the other hand, you can look at the remission was around 86%, and people who got a weight loss of more than 15 kilograms. Who had a weight loss of 10 to 15 kilos, it was 57%. So whenever you are losing more weight, there's a better chance for remission. Again, looking at the effect of intensive lifestyle intervention on body weight and glycemia in early type 2 diabetes. This is called Diadem 1 study. It is an open label, parallel group randomized control trial. Here also, we also show that definitely when you are able to put a lifestyle modification, reduce the weight, and definitely more people achieve the remission and reduction in A1C, reduction in the body weight. Again, and what are the major studies investing on the dietary interventions? One is that the direct study, which was conducted in United Kingdom. We have talked about it, 306 patients. They all give a meal replacement, meaning the shakes, followed by gradual reintroduction of the food before entering a weight maintenance phase. No, what was the definition? No glucose lowering medication, HbA1c of 6.5 and less, duration of more than 2 months, and remission at 1 year was 46% in the intervention group, and the remission at 2 years was 36%. Again, the Diadem study was done in Qatar, involving people from Middle East and North Africa, 147 patients. Here also similar meal replacement, similar cutoffs, and the intervention group had a remission of 61% at the end of 1 year. Again, the Vita Health study in the United States, which had a 349, they tried to use the ketogenic diet, and the same cutoff, almost the remission is 25% at 1 year and 76.6% at the end of second year. So the dietary strategies for remission of type 2 diabetes, whatever means you are restricting the diet, by doing a sleeve gastrectomy or gastric bypass or a low calorie diet or low calorie diet, you can look into that. The sleeve gastrectomy and gastric bypass, suddenly the A1C drops very faster. Similarly, the weight also drops faster. The later, after 2-3 years, it slowly picks up. When you look at the low calorie diet, it is not very drastic, but it drops slowly. So these mechanisms, by intervening the diet lifestyle, definitely by the low calorie diet, definitely helps in the process of remission in diabetes. This is a very low calorie diet in newly type 2 diagnosed patients. Almost 4 people have studied that. Lim et al., Steven et al., Lean et al., and Tegri et al. Almost type 2 diabetes with the 4 years, almost 6 years duration, the BMI ranging from 25 to 45, They try to give a VLCD, very low calorie diet for 8 weeks and 12 weeks duration, and they followed up for 2 months and 1 year period, and the remission rates were ranging from 46 to almost 100%. So the various studies, depending upon the protocol, they showed a different rates of remission. He is the man, Dr. Roy Taylor, MD, FRCP, the Magnetic Resonance Center in the Newcastle University, UK. What did he say? He only developed what is called the twin cycle hypothesis, as diabetes and reversal. There are two cycles. One is in the liver cycle, other one in the pancreatic cycle. Whenever there's a positive calorie balance, there's increased liver fat, resistance to insulin suppression of the glucose production, increased basal insulin secretion. On the other hand, when you look at whenever there's increased VLDL, the islet triglyceride increases. So there is a reduction in insulin response to ingested glucose. There's a pancreatic cycle. There's a postprandial glucose increase. Thereby, both can contribute to increase in the glucose level. And diabetes and remission in relapse, what happens? The type 2 diabetes, whenever the liver fat increases, there's increased liver fat export, there's increased pancreatic fat, and reduction in the beta cell function. By doing remission, what do you do? Reduction in the liver fat, reduction in the liver fat export, reduction in the pancreatic fat, and improvement in the beta cell function. So whenever these forces, whatever methods you are trying to reduce the calorie content, you are able to reverse it. Both the wheels will drive. So when you are able to reduce the both of them, the glucose level comes down. This is called Taylor's twin cycle hypothesis. Okay, whenever we reduce the weight, both liver fat as well as the pancreatic fat comes down, the insulin sensitivity increases, the glucose level falls down, insulin resistance drops down. So this is again related to weight loss. I already said, whatever may be the mechanism, whenever you are trying to produce a maximum weight loss, there is definitely the remission rates are higher. Already said, more than 15 kilograms, almost 80 to 90%. And people with 10 to 15 kilograms weight loss, around 60 to 80%. This again, people with the normal BMI also, they have tried to attempt the study. This is called retune study, which said that normal BMI people also, when a reduction in the weight can lead to remission in diabetes. Okay, and it's about retune study. And now we'll know who are all the people who can go in for a remission. Okay, we are not using a term reversal, because reversal, mind you, the reversal is a permanent phenomena. On the other hand, the remission is only a temporary phenomena. It means diabetes cannot be totally reversed. It can be only undergo a remission, which is a temporary phenomena. Who are all the better candidates for diabetes remission? The favorable markers are one with a fewer anti-diabetic medication, not on insulin therapy, lower A1C, newly detected diabetes. Okay, so their weight loss will be the strongest marker for the reversal. And again, what are the strategies for type 2 diabetes mellitus remission? So when you find a people with a very higher BMI, the bariatric surgery helps here in addition to lifestyle. Again, the metformin-based combination. And when the BMI is in 25 to 30, here the SGLT2 insulin plus metformin-based combination. And when there is a A1C is high, newly detected diabetes, they use a short-acting insulin. So these factors, whenever we're able to control it and reverse it, will push from left to right. On the other hand, when you keep on increasing the BMI, there will be pushing the progression to type 2 diabetes. So from right to left, you are able to reduce the BMI and weight by whatever mechanism you are going to limit the diabetes to normal glucose tolerance. So this is called precision nutrition program, and they also had different stages, and they try to look after 90 days. Stage 0, more than diabetes of more than 1 year, no medication and A1C of 5.7. Stage 1, no medication, A1C less than 5.7. Stage 2, again no medication, A1C 5.7 to 6.4. Stage 3, no medication, A1C less than 6.5. Stage 4 is metformin only. Stage 5, 2 oral medication. Here you can see after 90 days, the remission rates are maximum possible with the stage 3, no medications, and A1C of less than 6.5, and stage 4 metformin only. When you have more medication, the remission, patient was taking more number of medication, the chances of remission are less. This is the results of the precision nutrition program. And so the different types of diabetes have remitted better. Okay, and the different types of this severe insulin deficiency diabetes, each one so whenever the severe insulin resistance, the center one is severe insulin resistant diabetes, and where there is a remission is better with a weight reduction. So what is the consensus statement the diabetes care published regarding the definition and interpretation of the remission in type 2 diabetes? What is the optimal terminology? The resolution, reversal, remission, and cure. People use a different terminology. The correct terminology is remission only. The glycemic criteria, HbA1c of less than 6.5%, that is 48 millimoles, for at least 3 months without medication. Second, CGM devices, we can use that. Estimated HbA1c can also be used. Less than 6.5 can be considered. Diabetes, what is diabetes relapse? What will happen? So that's why we use the term remission. The weight gain, stress from other causes of illness, and continuing decline in the beta cell function can all lead to the recurrence of type 2 diabetes. So what about the diabetic complication following remission? Even after remission, the classic complications of diabetes, including retinopathy, nephropathy, neuropathy, and enhanced risk of cardiovascular disease, can still occur, mind you, all colleagues. Second, the long-term outcomes of this remission, the long-term outcomes of the remission on mortality, cardiovascular event, function capacity, and quality of life are still unknown. We need more robust data on this. And summary, the reversal of diabetes can definitely occur, but as we say in an advertisement or anything, the conditions apply. Thank you very much. Nothing is permanent in life. We're able to remit it at the earlier newly diagnosed diabetes. We're able to reduce the weight. Definitely, there's a possibility of remission. Thank you for the opportunity.
Thank you, sir. Thank you for the wonderful evidence-based speech. This was a wonderful talk. As you told, it is very clear. The term diabetic reversal should not be used. Only diabetic remission should be used. The basic problem with the diabetic reversal is the marketing strategies. Number two, as we all understand from his talk, the heterotopic deposition of fat or adipose tissue, whenever it comes down, there is a high chance of bringing down HbA1c to normal. Just 1 gram of removal of fat from pancreas can reduce the HbA1c to around 2 to 3. So that is the basic mechanism of diabetic remission. We aim to remove the fat from liver and from pancreas. For that to be achieved, there has to be a drastic step that has to be taken as far as the caloric restriction is concerned. And number two, the motivation. And number three, consistency. If it is not done, remission is not possible. But as usual, mankind aims for the best. And sooner or later, we will try to achieve it. We have few questions, like one.
I think Venko will take the question after Bhavadharini's talk.
Sure.
Okay?
Sure, no
Yeah.
issues, sir. We'll go ahead. That will be better. So next, we have our IMA teacher, Madam Dr. Bhavadharini Chelvan. So she needs no introduction. Of course, she is going to talk on a very important topic. Where does the NCD originate? Does it start only after birth or it starts from the fetus? So our researchers have gone to such a level that we aim to prevent the NCDs at the primordial level. So can we prevent any kind of NCD at fetal origin? So do we have a scope of preventing it? Thank you, madam. Please go ahead with your wonderful talk.
Thank you, Dr. Vengo Jayaprasad. And I respected all leaders in IMA, AMS, and all the delegates, faculties, and the chairpersons. Today, my pronouns to my mentor, Professor Dr. Seshia, who has come out with a path-breaking concept for the primordial prevention of diabetes based on embryology, endocrinology, and endorsed drug. Dr. Balamurugan's doubt is, he asked me whether it can be prevented, diabetes as such. You know, my mentor, he was knowing that diabetes is going to rule the future, and he had the forevision of starting a department for diabetes well ahead in the whole country. Then he wanted to start a course in this. He started diploma in diabetology, and he was spreading and helping to control diabetes. And he came out with a single-step procedure to diagnose GDM. But with all this, he was not able to bring down diabetes. It was continuously increasing. So he has come out with a new concept of the primordial prevention of diabetes, which we are doing at Chennai, Delhi, and we have succeeded also. Coming to the... So As Dr. Balamurugan asked whether diabetes prevention is possible, whatever I am going to talk is from my mentor, Professor Dr. Seshias. And to achieve a diabetes-free generation, whom to focus? Of course, it is the female gender is the key for diabetes prevention. Why we say and how? Because if you take the developmental origin, the ovum is well supplied with mitochondria, but the sperm contains only a few, and even those few do not persist in the offspring. So the entire, only the nucleus enters the ovum, and thus all the cytoplasm, mitochondria, and mitochondrial DNA all are exclusively maternally inherited. This is what long back David Barker said, that the body's susceptibility to lifestyle diseases is programmed in utero. What is this in utero programming? It is nothing but a process whereby the stimuli, that is the maternal fuels or stresses that occur at critical or sensitive period of fetal development, permanently changes the structure, physiology, and metabolism, which predisposes the individuals to diseases in late life. This is what we say, fetal origin of adult diseases. And Dr. Wengo's doubt, I think I'm going to clear today that it is epigenetic responses which leads to disease, that is the maternal and placental stress-mediated changes in fetal epigenome is responsible for the developmental programming and differential adaptation responses in the fetus, which can ultimately lead to phenotypic disorders, changes, and of course, all the non-communicable diseases. Coming to diabetes, is it an inherited destiny? That is, whether it is genetic alone or intrauterine environment. Remember, it is totally intrauterine environment.
Can you,
Exposure to a diabetic
yeah, once again,
in
Dr.
utero
Vijay, just
is
wait.
associated
Hello,
with
can you
increased
mute, please?
occurrence of
Hello? Hello? The organizers, can you mute the people who are not speaking? Hello? Excuse me.
See, those who are not listening, please mute your microphones. Hello? Please mute your microphones. It's disturbing. So exposure to a diabetic environment in utero is associated with increased occurrence of impaired glucose tolerance and a definite insulin secretory response defect in the adult offspring, independent of this genetic predisposition to diabetes. This we can see by animal experimental model. They have put the Vista rat with a low genetic risk of diabetes. When it is exposed to the hyperglycemic media of the goat rat, what happens? It significantly increases the risk of diabetes in adult life. And coming to the offspring of Paima Indians who are in utero when their mother had gestational diabetes had a greater risk of developing diabetes than earlier siblings born before the
The IT
mother.
wing, can you mute them? The IT wing, can you
Host
mute?
error, mute.
Sir, error host can unmute, sir, please.
So host mute பண்ணுங்க யாரோ somebody is disturbing. மேடம் கொஞ்சம் மியூட் பண்றீங்களா?
யாருன்னு கேட்கல அவங்க.
So the intrauterine milieu is the inherited destiny. That is the hyperglycemia in pregnancy, the glucose intolerance. For example, if you take in utero overnutrition, where the mother develops obesity, GDM, diabetes, here occurs epigenetic changes in every organ. And there is altered physiology causing insulin resistance and fetus dysfunction with increased risk of obesity, diabetes, cardiovascular disease in the offspring. Not only this, this is transferred from generation to generation. And again, if you take suboptimal in utero environment, again in malnutrition also, all the organs are affected and they in all the non-communicable diseases. So the environmental exposure causes DNA methylation changes, nucleosome changes, histone modifications, RNA changes. In this, the histone DNA methylation is very important, contributing the offspring to develop metabolic disorders like obesity, type 2 diabetes, and cardiovascular diseases. And so, having known that it arises in utero, when to predict GDM so that we can prevent GDM itself and all the consequences of GDM, that is development of diabetes itself. Of course, detection of diabetes, that is diagnosing, is very by our single step procedure given by the national guidelines. Your
Sir, the technical team, sir, it is possible to mute everyone? Hello?
Sir, host பண்ணலாம் host can unmute mute பண்ணலாம் sir.
One second, hold on.
Balamurian host can do it. Who is the host?
Yeah, wait a minute, we'll just try to. Oh, we are one second.
Sir, 1 minute, I will tell the host.
Thank you, sir.
Madam, நீங்க proceed பண்ணுங்க.
So, detection of GDM, that is
disturbance are there,
diagnosing
wait a minute.
GDM is very easy, but what we are concerned is prediction of GDM. We need to say who are all going to develop GDM. So, we can prevent the development of GDM, and it's when to test to predict this GDM. Of course, NIH has told National Institute of Health that we need to do the test in the early trimester. This will give ample chances to alter the lifestyle and prevent the diseases. This is at 10th week, we have to know whether she is going to develop diabetes or not. Why this 10th week? You take the development of the beta cells, it develops by 7 to 8 weeks and starts its function by 11th. So, before 10th week, we should control the blood sugar so the fetal pancreas is not made to function.
Madam, sing 1 minute, 1 minute, madam. The viewer Selena, please kindly mute your phone. Selena, please.
அவங்கதான் சார் செலினா மேடம் அவங்களுக்கு தான் வருது
Yeah,
voice.
please mute yourself. It is very disturbing. Please go ahead, madam.
Adnandus, after doing 40 years of study in the normal pregnant women who are all non-diabetic, he has told that fasting is always less than 80 and 2 hours less than 110. That is, it is not 110, less than 110 is normal. Any value above normal is abnormal. This 110, why I am specifying is, this is the fetal renal threshold. For us all adults, it is 180, whereas for fetus, the renal threshold is 110. So NIH has said that 5.3 or the corresponding blood sugar at 10th week predicts GDM because this is going to stimulate the fetal pancreas and it's going to secrete insulin with causing hyperinsulinemia. See, whenever the insulin cannot cross the placenta and enter the fetal side, whereas excess glucose can enter and stimulate the fetal pancreas to secrete more insulin, and this hyperinsulinemia causes changes in the adipocyte number, triglyceride deposition and hypothalamic functions, and even beta cell hyperplasia, all leading to the diabeticity changes. When this will occur, that if the fetal pancreas is made to work by more blood sugar, that this occurs at 11th week. So we need to maintain below 110. That's the main thing. What happens? This when the blood sugar in the mother is always high and it is low in the fetal side, so the glucose is transferred from the mother to the fetus, and again the hyperinsulinemic fetus, it steals more glucose from the mother. There is a risk of hyperinsulinemia in pregnancy, not diagnosed in most affected females because of the fetal handling of the mother's blood sugar. The mother's blood sugar may look normal, but the fetus will have all the consequences. So the postprandial blood sugar at 10th week predicts GDM. So what we need to do, we have to bring down the blood sugar before 10th week less than 110, so that the fetal pancreas is not stimulated. The obvious implication is this: glycemic control needs to be optimized very early in pregnancy to prevent the establishment of fetal hyperinsulinemia. That is, bring it less than 110. What is this fetal handling of maternal blood sugar? For example, if you see a pregnant lady at 10th week, her blood sugar is 126. She's coming for review at 12th week. It has come down to 112 without any intervention. How this has happened? Here again, the fetal insulin secretion has started, and this has brought down the blood sugar And this has handled the mother's blood sugar. So whenever the mother blood sugar is more than 110, immediate action has to be taken to bring down this. Otherwise, she'll develop GDM and all other non-communicable diseases. See, glucose crosses the placenta and increases the maternal hyperglycemia, pushes the glucose to fetus, and the fetus steals glucose. So the low glycemic control early in pregnancy will result in establishment of fetal hyperinsulinemia, causing an exaggerated fetal glucose steal. Because it is inside the womb, it can steal as much as one. So as a consequence, the overactive glucose steal will increase the disposal of maternal glucose into the fetus, attenuating the levels of maternal hyperglycemia. So we may miss the diagnosis of GDM in the mother. This effect of lowering maternal glucose driven by the fetus will be greatest in pregnancies with most hyperinsulinemic fetus. The priming of fetal cells may account for the persistence of fetal hyperinsulinemia throughout pregnancy and also throughout life. Even after birth, the baby goes for recurrent hypos because of this fetal hyperinsulinemia, and when it grows, it puts on weight, eats more because of more insulin. All this happens. So what we need to do, we have to take our actions well ahead. That is, at 8th week, you do a postprandial blood sugar. If it happens to be 110 to 190, you intervene with medical nutrition therapy as well as metformin. And this grace period is available to bring down less than 110 so that the fetal pancreas is not stimulated and no insulin secretion. But if you retain, see at 110, there's no period to bring it down. The fetal pancreas starts functioning and you get into all the problems. And if you take the organogenesis is complete by 8 weeks. So you need not worry about giving metformin. It's safe since the embryonic stage is over. And 120, 110, if you see, you can just put them on metformin till delivery. To use metformin as an adjunct or alternative to insulin in the pre-conception period and during pregnancy, when the likely benefit from improved blood glucose control outweighs the potential to harm. Again, very recently, they have shown that metformin is safe for use throughout pregnancy. That is, this is the first oral anti-diabetic that can be used from conception to birth. Not only this also reduces the hypertension and preeclampsia, which are all again due to insulin resistance. And this metformin is not tied to any growth differences at 2 years. It has well been given in the Lancet Diabetes and Endocrinology. But remember, administration of metformin after 12th week, that is after first trimester, will not be effective in preventing GDM because the fetal secretion of insulin has already started. So what is the scope for prevention of GDM? See, the 110 at 10th week predicts GDM. So for prevention, intervention has to start at 8th week because the fetal beta cells do not start insulin secretion at 8th week. That is in the embryonic stage, and metformin is safe because organogenesis is over. So how to categorize the glucose intolerance during pregnancy? Of course, we have GDM when the blood sugar is 140 or more by 75 grams of glucose given in the fasting or non-fasting state. And this is a stress hyperglycemia and a stress test for the beta cells, which predicts future type 2 diabetes. Again, by glucose load, when the blood sugar touches 180, between 120 to 140 itself, we get other adverse problems. This new term, the early gestational glucose intolerance, that is AGI, what I told, that is 8th week, you need to see a 2-hour postprandial sugar. If it is 110, start your action. This predicts future GDM. What are the consequences of this GDM? They have found that those who are overweight and GDM they have studied 9232 men and women aged 31 to 34 and found some sons born to these overweight ladies and GDM ladies, 40% of them happen to be infertile. And again, this is related more to childhood cancers. And this again interferes with the neurodevelopment. That is, it causes conditions like attention deficit hyperactivity disorder, autism, intellectual disability, developmental delay, epilepsy, and cerebral palsy. And this again raises the systolic blood pressure. So to conclude, female gender is the key to NCD prevention, and it starts with a healthy pregnancy if you want to prevent all NCDs. Both lower weight, that is malnutrition, and underweight, malnutrition, and overweight because of overfeeding all leads to these problems of obesity, diabetes, hypertension, and cardiovascular disease. It doesn't stop with itself. It is transmitted from generation to generation. That's the problem. So maternal health is a link to NCD epidemic. So the preventive measures against NCD should start early during intrauterine period and continue throughout life from early childhood. The womb is more important than the womb. It all starts in utero, and ends for diabetes-free generation focus on the fetus for the future. So just one blood test, that is 2-hour postprandial at the 8th week and starting action at appropriate time, prevents the generational transmission of diabetes. Of course, we have done studies and proved that the ladies are not developing GDM. Our mentor, Professor Dr. Seshia, always used to say that Indian problems need Indian research and solution. Likewise, and again, our Modi ji used to say, ask us to make everything in India. This Make in India concept for primordial prevention of diabetes is evidence-based, feasible, and doable. So, healthy children are the wealth of the nation. So, let us all pledge for primordial prevention of diabetes. We few alone can't do anything. Let us all join together for the primordial prevention of diabetes. Thank you.
Thank you, madam, for the wonderful talk and wonderful narrative, ending with a punchline as usual. So it was very nice to hear from you that any kind of primordial prevention we were talking earlier is not primordial prevention, is the primary prevention. So the primordial prevention goes back to not to fetus, to even embryo.
Yes.
Can we not go still back to the healthy ovum?
Yes, of course, we can do a pre-conceptional counseling and advise the adolescent girls to prepare themselves for fit to conceive. Should be
exactly, madam. So I think your next study would be on a healthy ovum. Before preconception, it should be better. Thank you.
Good evening, all the organizers. We have been talking very revolutionary topics. Last topic I saw, in between I listened to Dr. Bavadarani, how an aggressive manner she was putting forth her views. Definitely, see, medicine is a very fast evolving discipline. You see that, we have gone through so many crises. After invention of antibiotics, some drugs only, we are able to save people. Earlier to that, we used to lose all our patients. Even a small cut injury in the body, people used to die of tetanus. After the advent of all these drugs, tetanus is controlled, all of the diseases are controlled, we are able to save patients. At the same time, we are going through problems. And for example, let me take the cricket sports. If somebody who performed much better, for example, Sachin Tendulkar used to score hundreds and 200s. Suddenly he would pass a lean patch. Now everybody, he will go to his mentor and ask his advice. He would say immediately, go to basics. So I thought, it is some time or other we will have to talk basics. That doesn't mean that I'm an expert of basics, but at the same time, I try to use this opportunity to put forth all my experience points arise out of my own experience, so that now you will get some of the points very, very useful to you. Next slide. So what is professionalism? Professionalism, we all say that we are professional. Professionalism means in medicine requires the physician to serve the interests of the patient above his or her self-interest. That is called a professional. Patient is first. That's why we are called a professionals. All other things are next. Next slide. What are the elements? There are some 6 elements of professionalism. First one is altruism, giving priority to patient's interest rather than self-interest, and accountability, being answerable to patient, society, and profession. These are the very basic character of a doctor. I just want to highlight this. Excellence. Always try to do excel in our activities, so the best to the patient. So conscientious effort to perform beyond ordinary expectation. Our commitment to lifelong learning. Next slide. And duty. Duty is always, inconvenience. We will have so many works at home, still we go for duty because we accept the commitment. Whatever is our personal work, we will go and perform our duty to the patient. The honor and integrity, being fair and truthful, straightforward. And the 6th one is respect for others, patients and families, colleagues, and other healthcare professionals. And next slide. There are some commitments of professional doctor. This one I have taken from the Hippocratic Oath. If somebody follows these 10 commandments or 10 commitments, I think the problem will be very, very, very meager in their practice, like, strive for professional competence, honesty, patient confidentiality, maintaining appropriate relationship, improve quality of care, improve access to care, just distribution of finite resources, knowledge, all these things. I think these are all may look kind of nursery school teaching, but these are all the basics for every doctor. Next slide. And like that, there are basics for the students also. So there are same 10 commitments for a student. Similar to that, respect for professor and speakers and cadavers when they do anatomy dissection, and respect for institution, respect for the patient and families, respect for the patient confidentiality, respect for all members of healthcare, respect for the administrative support staff, and respect for core values of professionalism. This again I have taken from the Hippocratic Oath as I did for the commitments for the doctor. These are all very, very basic. Nowadays nobody teaches us, teachers in the classroom. These are all can be obtained from our teachers, our mentors. In every field, there are mentors for all our people. The mentors have the responsibility to teach all these things. Next slide. So what are the professional responsibilities? Like commitment to professional competence, commitment to honesty, the patients, commitment to patient confidentiality. Next slide. And commitment to maintaining appropriate relation with the patients, commitment to improving quality of care, commitment to improving access to care. Next slide. And a commitment to just distribution of infinite process resources. That means if you have some resource, you should be equally distribute, not to there is no discrimination for a poor patient or a rich patient. Everybody should be getting these resources equally. That's what it means. Then kind of commitment to the scientific knowledge, and commitment to maintaining trust by managing conflicts of interest. Next slide. And finally, commitment to professional responsibility, that is working collaboratively and treating one another with respect. Next slide. See, I have said these 10 responsibility, 10 commitments for doctors, 10 commitments for students, and 10 responsibilities. You may see that many of the points are repeating, but nevertheless, these were the basics of our medical profession. There are 2 self-tests. Self-test one would I like my dear and near to be treated as every time. This is very often you hear this. உங்க சகோதரினா இப்படி பண்ணிருப்பியா, உங்க மதர்னா இப்படி பண்ணிருப்பியா அப்படி நிறைய பேர் டாக்டர்ஸ்ல கேட்கறாங்க. That is true only, honestly true. So always we have the self-test that whatever patient we get treated like our near and ones, dear and near. Next slide. And also be transparent. There should not be any exploitation of patients because of their ignorance. Next slide. So what is the definition of success? Many people we say that this doctor is successful and this doctor is not successful. What is the standard by which they are saying this? There is no definite standards in the world. Still, we are talking that this is it depending on the person getting lots of patient every day, or he is getting new car every time, new plot, lots of money with him. Is it define the success of the doctor? Or if somebody is publishing papers in journals very frequently, is this the success? Or somebody is getting the name of very good teacher, is it means that he is successful? Next one. But I tell you, if you are a successful person, just visualize yourself. Next slide. Visualize yourself that your funeral will be attended by the speaker who is going to speak in your funeral. Your family member, your friend, or your colleague, or your patient. Suppose a doctor gets more number of patients to speak at the funeral of a doctor, I think he is the most successful doctor. All agree? Yes. Next slide. And today's successful doctor may be a clinician, good academician, and manager, or a financial expert, and CEO, family care provider, self-care. I read a story of a cardiologist in US. He is a very good, great interventional cardiologist. Have done lots of interventional angioplasties, and he is a good teacher also. Every time he makes round, there will be 50, 60 residents, cardiology residents around him. And then he became very famous that even the neighboring states used to come and attest. There are many people who got here also in Tamil Nadu. But unfortunately, he developed a pancreatic cancer and admitted in the same hospital. So immediately his assistant professor took over from him, and he started doing all the rounds. All his work, whatever he was doing, somebody has taken. And he wrote in his bibliography that that hospital, the department completely forgotten him. When he was about to die, even his sister came and given an undertaking that the hospital can dispose the body from their self. So that is the situation of a very famous doctor. I was really became emotional when I read the story in a book, in his own book. That is the stage of a very famous doctor. So what is the success? We will have to define. We will have to define and keep in mind always. Next slide. So, and there are a professional failure if you do not maintain all these commitments, and there are problems arising, lack of communications, and kind of things. The doctor themselves most of the time are at fault in getting a litigation notice. Next slide. So it is, I am very emotional, very passionate about saying this word very often, that successful medical practice is like successfully driving a car where, where you not only take care of your mistakes, but others' mistakes also. If somebody suddenly appear from, signal and wherever somebody's mistake also, you have to be very, very careful. So the medical profession is one such profession that we are taking care of the others' mistake also. Next slide. So now come to the second part of my talk, that I have done lots of homework to put this professionalism, a word forward, into a simplest form. I just want to tell you 6 points and finish. I have divided our profession into 6 parts. I wheel 6 posts of a wheel. Both are all 6 are important for smooth running of our profession. That's called wheel of professional excellence. Starting from professional skills, healthy mind, continuous learning, ethics, values, and morals, society connect, and then nation building. Next one, if you apply your, mark or achievement. Next slide. Hello? Are you able to hear me? The slide is not moving. Yeah, correct. So If you apply, you see that every spoke there is 0 to 10 points. 0 to 10 points. The nearest to the circle U is a 0. The nearest to the outer circle is a 10. If you mark a point, maybe you are about a 10, 8 out of 10, you will have a smooth wheel like this. Smooth wheel like this. If you get a wheel like this, I think you are professionally excelling in your career, in your medical profession. You understand this point? Yes. Now you say one by one. Next one. So professional skills. So how do you excel in your professional? I think this is only part of the wheel. That's what I want to emphasize. Part is one spoke of the wheel. You have very good skill in diagnostic accuracy, effective treatment plans, good surgical skills if you are a surgeon, if you are practicing evidence-based practice, staying up to date with the medical advancements, and getting peer review and feedback, and also developing leadership development. If all these 7 points, 7 areas of professional skills you are excelling, that means you are professionally very skilled and you do the best to our patient. Next slide. And you see that there are a few examples who have done exceptional work in their profession. And Barry Marshall recently came on the Zoom platform also for a webinar where he established that the peptic ulcer is caused by Helicobacter pylori by swallowing the broth of the Helicobacter pylori by himself. And then he asked one of his assistants to do a biopsy of his gastric antrum, proved that the Helicobacter pylori he swallowed some time ago colonized in his pylorus of the stomach. And the whole world believed that it is because the Helicobacter pylori and got a Nobel Prize for this. Come to Werner's Frostman, he wanted to show the world that you can introduce a catheter into a heart without stopping the heart or without causing any damage to the heart or to the life. So he cut open his own basilic vein. He introduced a catheter into that and took an X-ray and so the tip of the catheter is crossing his right ventricle. So he proved that you can do any number of catheterization to heart and formed the basis of today's angioplasty. So these are the people, and of course, Jacques Marquardt, he operated through telemedicine, surgery from one place. He was the first one to show that you can operate on a patient in a different continent and while you are in another continent. Next one. And this is the man, Patrick. He did another form of professional excellence by finding out a cloud box where the patient's data can be stored. And also he found out a new drug. He himself became a scientist and found out a new drug called Abraxane, and he patented the drug. Next one. Now, second spoke of the wheel is the healthy mind. This is very, very important to achieve professional excellence. This is my take actually. It's my own the submission to the entire audience that you get a healthy mind about the values, disciplines, honesty, and empathy, and mostly from the parents. The parents, how they grow their children, no? These are the values they inherit from the parents. Of course, from the teacher, about how to be human, how to discuss and win an argument in a medical, everything you learn from a teacher. From the senior colleague, how do you serve from the poor sincerely? There is my teacher, one of my teacher used to say, if you serve sincerely 10 patients, you would get one rich patient. That means that the blessing of these poor patients will get you more patients. So, science says that science treats the body, but the mind treats the patient. Next one. So, number third, in this connection, I would like to say that professional excellence. Why do you want to achieve professional excellence? Maybe you live like a average physician and you don't want to exert yourself or kind of work hard to become an excellent person. But if you strive for a professional excellence, you will definitely enjoy your work. And when if you enjoy, you have to commit something. You have to commit above our regular work. That's why then only you will get a enjoyment in life, enjoyment in career. There may be small thrills, and you have to celebrate. And always remember, care always, cure if possible. Next slide. Continuous learning. This is very, very important to achieve professional excellence. You know, there are lots of report, lots of publishments. There are about 80,000 things are published every year, as the statistics say. Altogether, 80,000 publications every year. And you will have to be track of this thing. Particularly, you have to learn about the diet, physical exercise, sleep, mental health, and all these areas, 5 areas where you may educate your patients. Not only you educate yourself and educate your patients. If you have a up-to-date knowledge about these 5 areas, then patients, and you share this to your patients every day, what is the update regarding the diet, physical exercise, sleep, mental health, hygiene, then you are the best doctor for them. You definitely excel in professional excellence. Next slide. And always remember the old type of medicine, that is holistic medicine. Old is gold, but the new may be a diamond. But don't forget, it is the gold that holds the diamond. You know, so the gold means our older teaching of bedside medicine, touching the patient, talking to the patient, healing the patient through your good talk. All these are still relevant. The newer advancement technologies are like a diamond. If you are strong in holistic medicine, definitely the diamond will shine. High technology and high-tech technology, you all know this. Intergenerational leading, attend all CMEs, and also you have judicial use of modern technology in the present career of medicine. Next slide. So education of the doctor, which goes on after he has a degree, is the most important part of his education. That means after finishing your college, whatever you learn is very, very important. Next slide. Ethics, morals, values, adhering to the medical ethics and standards, very, very important today. This is all very important pillar of medical profession today. Respect for patients' autonomy, accountability, transparency, integrity and honesty, no exploitations of patient and ignorance, and also empathy. So I need not elaborate. You all know that what is ethics, values, good or bad. Moral is the responsibility and accountability. Next slide. Coming to the 5th one of professional excellence is the society connect. What I mean is contribute as much as you can to the society because of your degree, because of your knowledge, because of your resources, by virtue of resources. I would show a best person for a role model is Dr. Muthulakshmi Reddy. She was the first woman doctor to practice in Tamil Nadu. And she could have made a lot of money because she was the first woman doctor. She was having roaring practice. But she wanted to establish a hospital for cancer patients. She tried very hard. She was working, loitering here and there, running pillar to post, get a piece of land in Chennai. That time itself, it was very, very difficult. So she tried very hard, got a piece of land, and she developed this Adayar Cancer Institute. And before she died, he could establish, he brought his own son, Dr. Krishnamurthy, and subsequently Dr. Shanta joined us. But today, Adayar Cancer Institute is like a banyan tree, which is serving not only people in Tamil Nadu, the entire country. Next slide. And we have established in our own Erode that Imam Cancer Home, because there are a lot of terminally cancer patients having miserable terminal life. So to give comfort, because as I said earlier, we are not going to cure them, at least comfort them. And it is still running. We have completed 18 years of service to society by having a 1,200 cancer patients till their last life. Next slide. And time and again it is said that There are so many malnourished children are living in this world. In fact, the third most populous malnourished children are said they are living in India. So whose job is to address this? The government is one part doing this, but as a doctor, next one. And we have started again in Europe a program called Water Sartam, identifying malnourished children, either they are undernourished or stunted or severe acute malnutrition. Depending on that, we are treating them and bringing them back to normal, gain their height and weight normally. Next slide. And like that, we have done lots of work. Doctors joined together, lots of work during in COVID, treated more than 3,000 people. Next slide. So this gentleman, I would like to show that is Jeff Brown. We have done so many things here in India, but this man did a very, very, very risky thing, very applaudable thing that during Ebola pandemic in Liberia, in his native place, every doctor were leaving the country because of this fear of getting Ebola disease. But this gentleman, Jeff Brown, is a surgeon. He graduated from UK. He said, bring all Ebola patients to my house. I will treat the house. So he started admitting. You see that he was wearing all glasses, everything. He treated 200 patients. It has out itself. That's why the Time magazine framed his face in the cover page, saying that is a man or the person of the year. Next slide. He is the man, Jeff Brown. Next slide. Coming to the last important point of professional excellence is contribute to the nation building. I will show you what is nation building means, that you contribute to the healthcare industry, you contribute to the all spheres which are affecting healthcare. And you say Pratap Singh Reddy, he brought in world-class treatment in India, and he became very popular. His hospital became popular. You can see all the VIPs, minister, everybody getting admitted, not because this thing, it is a name and fame is that, but for the quality of the treatment. Next slide. And like the Satish Shetty, he devised a methodology to treat all poor children freely, all cardiac surgery freely from the remuneration he got from the rich patient. Next slide. Govinda Pankaj established Aravinda Hospital. Again, he developed a scheme of treating poor patients after charging rich patients. Next slide. So, my dear friends, coming to the last few slides, I think every one of you has to share some of your time and energy for the sake of the society and for the sake of the country. And you definitely will have a fulfillment of a professional excellence. Next slide. And you have to develop a leadership quality. If you want to be professionally excelling, you need to have a leadership, and it should be about the personal leadership. Next slide. So personal leadership is the one which progressively you achieve all your goals. Next slide. So I like to quote finally about Bharati, what he said. Namirikkum Nadu Namadu Enbadu Arindum. It is our country, it is our nation, it is our society. If you do not have any connect with the society or the country, I don't think one will be called as a professionally excellent man. Next slide. And the doctor may be a professional leader in the hospital, and also you should be a professional leader in the society. Next one.
And we'll move on to the next talk of the day. We'll call upon Dr. Balamurugan Namachivayam, a neurologist from Salem, MBBS and MD from Tanjore Medical College, DM Neurology from Nimans Bangalore, gold medal in MD General Medicine, and Ibrahim Bailey Moration in Epilepsy and Tropics, best paper in API 2005, Teacher of Excellence Award, Doctor's Day Award. He has contributed many texts to the textbooks, as well as more than 25 publications in PubMed Index journals, more than 100 guest lectures in national and international medical conferences. He is a course director in the fellowship in neuroemergencies by the Indian College of Emergency Medicine. Also, he is currently director and consultant neurologist of the SIMS Chellam Hospital, Salem, Tamil Nadu. He will be talking on approach to tremor. Over to you, sir.
Thank you, sir. Thank you, Dr. Balamurugan. My name is, and is my slide visible, sir?
Yeah.
Okay.
Yes.
The talk is on approach to tremor. First of all, I thank the Indian Medical Association Academy of Medical Specialities, the national leaders and the Coimbatore leaders. And my special thanks to the organizers for asking me to give the talk on an approach to tremor. And my special thanks to Dr. Balamurugan, my name it. And tremor by definition is to and fro rhythmic oscillation of a part of the body around a fixed joint. There are two components, rhythmic and oscillatory. Rhythmic is regularly recurrent and oscillatory is rotating around a central plane. The two components, if it is there, you are very clear, it's a tremor. Otherwise, you may be dealing tremor mimic and misdiagnosed as a tremor. So this is a rhythmic, what you see here. And this, I'm comparing. On one side is a rhythmic, and second, the other side, the next one is arrhythmic. So rhythmic is a tremor, arrhythmic is myoclonus. We don't call fine tremor, coarse tremor. We call as a rest tremor, action tremor. That I'll come to the later. So this is rhythmic, it's tremor, and arrhythmic is myoclonus. If it is in the leg, you can see it's rhythmic, and here you can see arrhythmic. So this is tremor, this is myoclonus. That part you have to be very clear, number one. Why I have included the oscillation. So you can hear there is a to and fro oscillation. That's a classic of tremor. It's like your pendular nystagmus, to and fro oscillation. A rhythmic. Here, you don't see that oscillation, you have a jerky component. So this is moving to, this is not tremor. And again, you can see here a jerky. So one phase is fast, the other phase is slow. So it's like a jerky nystagmus. So this is a non-oscillatory. So if it's a rhythmic and oscillatory, the step one in approach is easy to tremor. You are very clear. You are dealing with tremor, not tremor mimics. Then, what's the type of tremor? Is it a rest tremor or action tremor? Which is again, it could be partial or kinetic. The best way of examining the rest tremor is ask the patient to keep their hand or the examining part at rest or in the desktop or in the laptop. You can see, ask the patient to keep their arm that way. So they can use, you can see the rest tremor in the hand, outside the hand for partial tremor, and finger nodes or finger test is for kinetic. The prototype of rest tremor is Parkinson's tremor. The prototype of partial tremor is essential tremor. The prototype of kinetic tremor is cerebellar tremor. That's all very simple. So you should classify, is it rest, partial, and kinetic? Forget about all this thyroid tremor, alcohol tremor, fine tremor, coarse tremor. No. International classification of movement disorder is divided, made very simple, rest, partial, and kinetic. Then the onset and temporal course gives you the likely etiology. Only 5 tremor symptoms as well the acute and subacute is concerned, and only 5 symptoms as well the chronic is concerned. There may be overlap. Rest tremor with the Parkinsonism, partial bibrachial tremor can happen in the both sides. We will go one by one. This is a gentleman, acute or subacute onset. I am going to deal for the next 10 minutes. This gentleman underwent coronary stenting and was on dual antiplatelet therapy with PPI. Presented to us for evaluation of slowness, subacute onset progressed over 2 weeks. So you could see the patient's face, and then obviously he's having a mask-like faces, drooling saliva, and swallowing difficulty, tongue tremor, bradykinesia, cordial rigidity. So it is a Parkinsonism. So why Parkinsonism within just 2 weeks? Subacute onset, isn't it? When we went to the history and drug history, we could see he was on PPI with the L. L is levosulfide. Levosulfide, after stopping the levosulfide, you can see the same patient at the end of 2 months. So again, one more patient you can see presenting with jaw tremor and mouth tremor. It's called a rabbit mouth syndrome. And it took nearly about 4 months after stopping the levosulfide. She improved. Still, she's having mild tremor. So levosulfide or any dopamine receptor blockers like neuroleptic sarin is what we commonly give, or antiemetics, metoclopramide, can produce rest tremor with Parkinsonism, acute and subacute. Drug-induced Parkinsonism may take 2 to 6 months to resolve after withdrawal of the offending drug. And one of the most commonly used or abused drug is levosulfide. It is used in India as an prokinetic agent, but in USA it is approved as an antipsychotic, atypical neuroleptic. It is a substituted benzamine antipsychotic. If you want, one message I want to convey to the audience is that levosulfide is antipsychotic. Because right and left, we started using levosulfide with pantoprazole L and rabiprazole L, or LLL. It's not levo. That means that like a S-omeprazole, levo-omeprazole. No, it is levosulfide. You are combining an antipsychotic. So this produces acute Parkinson's, a new epidemic in India. It started from 2009, and you can see a lot of reports coming from major cities of levosulfide movement disorders. The next group is acute subacute onset partial or bibrachial tremor. So if they have a partial and bibrachial, you may think it could be an essential tremor, but if it's acute and subacute onset hyperthyroidism, drug-induced, most likely antidepressant. Some of the people after SSRI come with some mild tremulousness, don't think that they are having psychological issues or essential tremor. They are having essential tremor-like partial tremor due to drug, and especially from the cardiac angle, they may be on amiodarone for months together. It can produce a partial tremor and bronchodilators. The third group I call as ICU tremor, the most common form of tremor in the acutely ill patients, a rhythmic cortical myoclonus. I said the myoclonus is arrhythmic. There's one exception. Cortical myoclonus and palatal myoclonus may be rhythmic, and we call it a tremor. And it may be having a multifocal positive or negative myoclonus, and they are irregular. They may be rest or they may be partial kinetic, and most often it's a systemic illness or death, or sometimes infectious agents. So here is a patient who had presented with a high blood sugar and sepsis. You could see a patient having tongue tremor and neck tremor. And when we ask the patient to get up, he's having a body tremor and tremor everywhere. So one of the best examples, is a delirium tremors. So in addition to the tremors, they will be delirious. Here, they can have only tremor. It may be a positive or negative tremor, or myoclonus also may be combined. So this patient turned out to be 2 days later, after controlling the infection and the sugar, and you can see the absolutely normal, no myoclonus, no tremor at all. So the common cause for whole body tremulousness, acute, subacute, is infections or metabolic or deaths. Whenever you come across with acute focal or unilateral tremor, it's most likely a vascular event. Cerebellar-thalamic pathway stroke, it may be infarct or hemorrhage. Mostly they are intense tremor, it may be a rest tremor also. Here is a patient who presented with whether we could call as a tremor or an incoordination, but as far as the classification is concerned, it's a kinetic tremor. They are not able to reach the target. They have an imbalance in coordination. So it comes under the third group, kinetic tremor. As I said, that the prototype is cerebellar tremor. But acute onset, focal, always stroke you have to remember. The last one, acute subacute, is a psychogenic, especially students of 9th, 10th, 11th, 12th, 9, 10, 11, 12 syndrome, I call. And the stress they undergo nowadays with all the exams. And you can see this patient's tremor is bizarre. So sometimes it's at the wrist, and carefully if you see, you could see I'm diverting her attention, and the plane of the tremor has moved from the wrist to the metacarpophalangeal joint, and highly variable character. So this is a classic of psychogenic tremor. So we have seen acute and subacute. So rest tremor with the Parkinson's, most often drug, partial bibrachial, again most often drug, whole body tremorless with myoclonus, metabolic most often, focal unilateral tremor with associated signs, it's a stroke or demyelination, psychogenic. That's all. What are the things that you should not miss in acute subacute? This patient had presented with psychiatric illness, had suicidal tendency and family history of psychiatric illness, and she had classical rest tremor, no doubt, and some amount of mild dystonia is also there in the hand. So she's just splitting, and it's very obvious by looking at the eyes. It's a carrying. So never miss a Wilson disease, subacute or circuit. Any movement disorder less than 40 years, you have to suspect Wilson disease because it's a treatable disorders if you recognize here. In fact, especially 6 months to 24 months, coming with the pallor or pigmentary changes of the skin and brownish discoloration of the hair and tremor of the body or limbs and the developmental regression, especially exclusively breastfed infants or the mothers with vitamin B12 deficiency and age between 6 months to 24 months. So most likely it's infantile tremor syndrome. It's well known in India. And earlier we thought it's a iron deficiency, then protein deficiency, magnesium deficiency, calcium deficiency, zinc deficiency. Now the evidence says it's most likely B12 deficiency, and they respond well to parenteral B12 therapy. Next, we move on to the chronic. So again, the 5 syndromes. The initial 2 is like rest tremor with the Parkinson, what I told in the acute, and the next one is a partial kinetic or bibrachial essential tremor. So we'll move on. So rest tremor with Parkinsonism, it's a chronic one. So it can start as unilateral, continuous. Usually it's asymmetric in onset and in progress bilateral, but again, most of the time there will be asymmetric. Any limb may be involved, mostly upper limb. Slowly worsens in severity, may be the only symptom in tremulous type of Parkinsonism. But when you say Parkinsonism, other features of rest tremor, bradykinesia, rigidity, loss of partial reflexes, flex, partial freezing, you have to carefully look to make the diagnosis of Parkinsonism. At least 2 will be there. There is a rest tremor with Parkinson's, what we call as a pill rolling, and what you call is here as a drum beating. So our Parkinson patients are secular. They have pill rolling and drum beating also.
Cleaning cell charge இல்லையா? Charge இல்லையா?
Hello.
Coming, can you mute, please? Sir, who is not? Speaker, kindly mute, please.
Amount
Hello?
Sir, amount
Sir, who is talking, sir? Can you mute, please?
Sir,
Hello?
Dr. Ilayaraja வருது சார், இளையராஜா.
Ilayaraja.
Can you mute, sir?
Ilayaraja.
Admin should mute. Yeah.
So this is a battery off. This is the patient who underwent deep brain stimulation. So this is a battery off and this battery is on. Now you could see the difference. A rest tremor. So this is battery off and battery on. So it's a classical example. What you saw is a Parkinsonism. Now partial tremor, outstretch the hand, or you can ask the patient to keep this way. So this is a tremor, partial tremor, and bibrachial. So this is very classic of essential tremor. Earlier we call it a benign essential. It's not benign because most of the time it can affect the activity of daily living. It's maybe familial in 1/3. So benign familial tremor is now called as essential tremor. So it's need not be familial all the way. So when you ask the patient to draw the circle, you could see this is what we call as the Archimedes circle. So obviously this one is mine. This is the patient. You can see that rose petal sign, what you call them. And when you ask the patient to say, so there will be one tremor that's very classic for essential tremor. There will be shaky. Whereas in Parkinsonism, there will be hypophonia. Here, there will be shaky voice. What we call voice tremor is most commonly in essential tremor. And action tremor with ataxia, most of the time hereditary ataxia, they will be having a obvious other signs like incoordination and pyramidal signs and eye movements. And dystonic tremor is very rare. I skip this topic. And enhanced physiological tremor, this is most of the time young individuals come to us. Normally, it's not visible under ordinary circumstances. Now, we all may be having a very low amplitude, high frequency physiological tremor. And if you take a strong coffee and you may be feeling the tremor. But the physiological tremor turns pathological, especially when we attend the first anatomy or the biochemistry oral exams, practical exams. So especially in fear, flight, fatigue, and fever, people may be having mild tremor. So hypoglycemia, pheochromocytoma, thyrotoxic may aggravate that. But the classic feature to before reassuring can say that the disappearance of the tremor on removal of the precipitating event. Okay, so that will reassure the patient and the doctor also. So physiological tremor, no need, reassurance alone is needed. So in chronic, we again divided 5 syndromes. Not to be missed is action tremor with ataxia, especially when they have, you may be thinking it's a cerebellar ataxia, MRI may show cerebellar vermis atrophy. You may be telling that it's probably a cerebellar degeneration, but always try timing. That's what, even with cerebellar degeneration, they improve very well. So next one is autoimmune cerebellar degeneration is coming up a lot with the availability of newer investigations, antibody assays. Even the MRI is initially normal. They respond well to the steroids or immunomodulators. And drugs, lithium, phenytoin, amiodarone, all those things you have to be carefully look when you are looking at the chronic action tremor with ataxia. And the other one, in the extremes of age, we said that the infantile tremor syndrome, acute, subacute. In elderly, a chronic orthostatic tremor most often starts at the 6th decade of life. They won't present to you with the tremor. Most of the time, they present with unsteadiness on standing and high frequency tremor in the leg. So the complaint is most of the time not the tremor. Due to its high frequency and low amplitude, orthostatic tremor may be difficult to appreciate on visual inspection. And this is one condition where we put the stethoscope in the calf muscles or the thigh muscles, and you can see helicopter landing sound like that way. So EMG is a classic, we call it a helicopter sign, and they respond well to clonazepam. So this tremor is orthostatic tremor, and you can prevent fall. And the most common practical issue that we face is that is it essential tremor or Parkinsonism, sir? Because this patient is having a combination of this and that. Don't worry. Even in expert hands, when you look at this particular chart, intake diagnosis of essential tremor, nearly 60% only had essential tremor at the end of the evaluation. So there's a chance that essential tremor may be misdiagnosed as Parkinson's disease. And another study says only 44% turned out to be essential tremor, though the initial diagnosis is essential tremor. This happens even in the expert's hand. So how to differentiate essential tremor, which is usually a milder or benign, whereas Parkinson's tremor is usually progressive and a form of degenerative disorder. Essential tremor is bilateral. Parkinson's tremor starts as unilateral, but it may be bilateral. Usually starts as unilateral with obvious asymmetry. Most common component, I said that there are 3 components of a tremor: on rest tremor, and partial tremor, and kinetic. In essential tremor, the partial or kinetic is more than the rest. In Parkinson's, rest tremor is more than the partial tremor. And alcohol gives benefit. Alcohol gives benefit to 3 people. One, the government. Second, the manufacturer. Third, the essential tremor patients also have benefit with alcohol. And the Parkinson's tremor, they don't get benefit with alcohol. And nowadays, people say that this marijuana, medical marijuana gives benefit to the Parkinson's tremor. Very interesting to note, and a lot of medical marijuana has started coming for epilepsy and Parkinson's also. And obviously, 1/3 will have family history in essential tremor, less than 10 in Parkinson's disease. And other Parkinson's features that we want to discuss are bradykinesia, rigidity, and partial instability, freezing, flux posture may be there in Parkinsonism, not in essential tremor. And if you have tremogram, you can classify these things with the frequency which is there. And one practical point is that when they have severe tremor, you can ask the patient, see, this patient is having tremor in the right hand and left, but left more than the right. Partial tremors, the hands are out of phase. When she holds with the left hand, tremor disappears. Isn't it? So that's one clue to say it's more like an essential tremor. Whereas in Parkinsonism, he is having a rest tremor, and I'm asking the patient to hold both the hands. So, see, observe, he's not able to control it. So this differentiate, is it out of phase or in relation to the phase, differentiate essential tremor and Parkinsonism, and end stage, when they have a combination of all, you can do the simple test. And my take-home message is very simple. Whenever a patient is coming with involuntary movement, if you suspect tremor, the first question you have to ask is tremor, rhythmic and oscillatory. If it's arrhythmic, it's most likely myoclonus. Once you are clear it's a tremor, what's the type of tremor? Is it rest tremor or partial or kinetic? Rest tremor is most likely Parkinsonism, partial tremor is essential tremor, kinetic is cerebellar or cerebellothalamic tract involvement. If combined, which component is predominant, then again you can classify. Onset and temporal course, acute, subacute, drug, toxins, and vascular event. If it's a chronic Parkinsonism, essential tremor, and cerebellar degeneration. Not to, if you have a doubt, again you can go with other associated neurological findings, especially in Parkinsonism and in kinetic tremor, cerebellar signs, and not to be missed, infantile tremor syndrome, especially in India, and Wilson disease, any person coming with any movement disorder less than 40 years, and elderly people, you should not miss a thiamine deficiency, and you should not miss orthostatic tremor in elderly. With this, I think I'm on time, and I thank for your patient listening, my Simsalem team for their involvement in picking up and recording all these videos, and I special thanks to all my patients for allowing me to share their sufferings. Thank you.
Thank you, Dr. Balamurugan, for an excellent talk. We're running short of time, so we have the questions at the end. We'll move on to the next session and hand over the session to Dr. Priya, cardiologist, our IMA president of Coimbatore, and Dr. Usha, professor of medicine, KMCH Medical College, to take over the next session, please.
Thank you very much, sir. So my apologies, I couldn't join in the beginning as I had an emergency. So moving on to the last session for today. The first session will be by Dr. Ranganathan, an eminent cardiologist from Pollachi, Aram Medical Foundation. He will be talking on STEMI mimics.
MI
Over to you,
mimics.
Dr.
MI mimics.
MI mimics, sorry. Over to you, Dr. Ranganathan.
Thank you, ma'am. Now I'll start sharing my screen. Is my screen visible?
Yeah. Make it work. Yeah, fine.
Very good evening to one and all. At the outset, I'd like to thank the Coimbatore IMA for giving me this opportunity. The topic for today is MI mimickers. It's STEMI mimickers and MI mimickers. Both are the same. It's ST elevation and myocardial infarction mimickers. So this is the outline of my talk. For the next 15 to 20 minutes or so, take you all through the following topics. We'll see what is the diagnostic criteria for ST elevation myocardial infarction. It is very important to know this first before we talk about the mimics. We'll also look into what are STEMI mimics. Why do we need to know about these mimics? How do we differentiate STEMI from STEMI mimics? And then I'll show some case examples and conclude my session. So what is ST elevation myocardial infarction? There are a few words which I want to highlight here. ST elevation myocardial infarction is a clinical syndrome. It is characterized by symptoms of myocardial ischemia. This is extremely important. A patient presents to the hospital, ECG shows ST elevation. You just don't make the diagnosis of STEMI. Its symptoms are very, very important. All the diagnosis is based only on the presence of symptoms. So symptoms of myocardial ischemia with ST elevation in the ECG constitutes ST elevation myocardial infarction. And this ST elevation in the ECG has to be in at least 2 contiguous leads. What is the amplitude of ST elevation? What are contiguous leads? All those things we'll see in the coming slides. Now, what is STEMI mimic? STEMI mimic is a condition wherein the ECG shows ST elevation, but the patient does not have a myocardial infarction. To put it in simple terms, the patient does not have any coronary obstruction. The epicardial coronary vessels are patent, but still the patient has ST elevation in the ECG. So these patients come under the category STEMI mimics. So how do we identify STEMI from STEMI mimic, and how do we approach patients with STEMI mimics? Why do we need to know about STEMI and STEMI mimics? Supposing a patient presents with ST elevation MI, it is very, very important for the treating physician to initiate reperfusion therapy as quickly as possible. This is because time is muscle. When the epicardial coronary vessel is totally occluded, it is very important that we restore the flow, or else we are going to lose the myocardium. So we need to differentiate if it is a true ST elevation MI or is it a MI mimica. If it is a mimic and if you are going to thrombolize a patient with ST elevation but does not have occluded coronary vessel, then it is going to be detrimental to the patient. So how do we find out STEMI mimicus? Failure to recognize STEMI mimicus can lead to inappropriate use of resources like inappropriate use of thrombolytics, exposing the patient to unnecessary risk of thrombolysis and unnecessary risk of radiation exposure, not only for the patient but also to the treating cardiologist, and increased rather than decreased morbidity and mortality. Now we were talking about STEMI mimics. STEMI mimics, as I told you, is just that there is ST elevation in the ECG, but the patient does not have myocardial infarction. So what are the conditions that can mimic a ST elevation MI? There are few conditions listed here. One of it is LV aneurysm. This can be a consequence of old myocardial infarction. A patient might have had an anterior MI maybe 10 years ago, 2010, he might have had anterior myocardial infarction. He might not have been treated properly then. The myocardium would have necrosed, it would have become non-viable, and that part of myocardium would have become aneurysmal. And that patient with aneurysmal left ventricular myocardium will present with persistent ST elevation in the ECG forever. So that is one of the causes for STEMI mimic. The other causes are myopericarditis, stress cardiomyopathy, also known as Takotsubo cardiomyopathy, early repolarization syndrome, left bundle branch block, Brugada syndrome, hyperkalemia, hypothermia, hypertrophic cardiomyopathy. These are all several other causes of MI mimics. So what are the tips to differentiate? A patient comes to the emergency, the staff comes with some vague chest pain, staff takes an ECG, ECG shows ST elevation. How are you going to differentiate it from? You need to differentiate it from a mimic. Is it true myocardial infarction or is it a MI mimic? So history and clinical examination is extremely important. You need to go and ask the patient, is the pain compressive? Is it retrosternal? Does it radiate to the arms? Does it radiate to the jaw? Is it a typical anginal pain or is it a localized pricking type of pain that aggravates on inspiration, which is a non-cardiac pleuritic pain? So history is very important. Any patient with myocardial infarction, the ECG changes evolve over time. The first minute you take ECG, it's different. 15 minutes later, ECG changes evolve. 1 hour later, it keeps evolving. 2 hours later, it keeps changing. So ECG changes, they keep changing over time in patients with acute myocardial infarction. Patients also have reciprocal changes. I'll show you what a reciprocal change is in the coming slides. And ST elevation in a patient with myocardial infarction follows a typical coronary distribution. Comparing with old ECGs also helps us in most of the times to differentiate a true MI from a mimic. And we also have investigations like cardiac biomarkers, echocardiogram, and coronary angiogram to help us out in some odd situations. So these are the tips and tricks by which we differentiate a mimic from a true MI. I told you already, ST elevation, for us to diagnose ST elevation myocardial infarction, the ST elevation has to be in at least 2 contiguous leads. 2 leads are said to be contiguous when they look at the adjacent aspects of the heart. Look at this picture, for example. This is a hexaxial reference system. Lead 3, AVF, and 2 are shown here on the lower aspect. These look at the inferior surface of the heart. So ST elevation in lead 2, lead 3, and AVF means the ST elevation is in contiguous leads because these 3 leads look at the inferior surface of the heart. If, for example, there is ST elevation in lead 1 and AVL, again, these 2 leads are contiguous because both lead 1 and lead AVL look at the lateral aspect of the heart. Supposing a patient has ST elevation in lead 1 and ST elevation in AVF, these are not contiguous leads, and this probably is not ST elevation myocardial infarction, and we need to look into this patient carefully because lead 1 looks at the lateral aspect and lead AVF looks at the inferior aspect. So these 2 leads are not contiguous leads, and presence of ST elevation only in lead 1 and AVF does not fit in the criteria for ST elevation MI. This will help you understand better. You can see the a 12 lead ECG shown here on the left side of the screen. A patient has ST elevation in this red part, then this is contiguous leads, lead 2, 3 and AVF, so we call it inferior MI. Likewise, if there is ST elevation in V2, V3 and V4, these are contiguous leads and we call it anteroseptal or anterior wall myocardial infarction. So ST elevation in a patient with myocardial infarction follows a coronary distribution. It can be inferior, it can be anterior or anteroseptal, it can be lateral, or it can involve both lateral and anterior, wherein we call it extensive anterolateral MI. Look at this ECG. There is contiguous more than 2 mm ST elevation in the inferior leads, along with reciprocal ST depression in lead AVL. What is reciprocal ST depression? ST depression is said to be reciprocal when here we have inferior wall myocardial infarction. The opposite territory is the lateral wall. So when there is ST elevation in inferior wall, there should be ST depression in the opposite wall, which is lateral wall. This points towards true myocardial infarction. This is one of the important factors to diagnose acute myocardial infarction. Another example here, there is contiguous more than 2 mm ST elevation in V1 to V3 and reciprocal ST depression in lead 2, 3 and AVF. Both these points favor acute myocardial infarction. It's a true myocardial infarction. And importance of serial ECGs. This also helps us in a big way to diagnose true MI from MI mimic. You can see here, when you take an ECG, in the initial 30 minutes, the diagnostic yield of an ECG for MI is only 33%. The next 60 minutes, it goes up to 60%. The diagnostic yield goes to 72% by 90 minutes and close to 80% by 120 minutes. So the first ECG does not give you enough evidence. Put the patient in observation, keep repeating the ECG again and again. If the symptoms are suspicious, please do not just do a tropy, the troponin and negative, please do not send the patient home. Admit the patient for observation, keep repeating the ECG, because the more you repeat the ECG, higher is the chance that you will make out a finding. This is an example to show the importance of serial ECGs. A patient presents to the emergency with a vague chest discomfort, not very classical though. So this first ECG taken at 11:52 p.m. You can look at the first ECG, not much changes. There's probably loss of R wave and V2, otherwise nothing. Another ECG 8 minutes later, and someone who is very keen on reading ECG will be able to pick up. You can look at V3 and V4, what we call as De Winter's sign. There is upsloping ST depression in V3 with a prominent tall T wave in V2 and V3, which is a marker of coronary occlusion. It is a pre-runner of anterior wall myocardial infarction. So the initial ECG taken 8 minutes ago did not reveal much, but this repeat ECG after 8 minutes shows this. The other ECG after 2 minutes, you can see the ST elevation now picking up in V2, V3 and V4, and look at the ECG after 10 minutes. From 11:52 to 12:06, the last ECG after 10 minutes, there is gross ST elevation in anterior leads with reciprocal ST depression in inferior leads. So it's extremely important to keep repeating the ECG when you have suspicion. As we discussed previously, any patient with acute myocardial infarction, the ECG change does not remain static, it keeps evolving. You can see the normal QRS morphology in the first cartoon, and then the T wave increases in amplitude and the base of the T broadens, and then ST segment elevates, then Q forms, ST elevation persists and T starts to invert. And once reperfusion occurs, ST elevation dissolves, T inversion persists, and at a later date, Q persists, ST elevation settles, and T wave normalizes. This is the evolution of STT changes in a patient with myocardial infarction. So now I'll show a few cases. This is a 42-year-old gentleman, not a diabetic, not a hypertensive, has had the history was he came home, he is a farmer, he went to the farm, came home for lunch, sat for lunch at around 1:30 p.m., suddenly collapsed. In a couple of, not even a minute, wife says he woke up by himself. He had profuse sweating, he was brought to the hospital. This is his ECG. So is this anterior wall myocardial infarction or anteroseptal infarction, and do someone want to lyse this patient. This patient did not have any chest pain. This patient does not have any comorbidities. He does not smoke. He does not consume alcohol. So what did we do for this patient? We did a troponin. It was mildly elevated, not significantly elevated. Echo showed normal LV function. There was no wall motion abnormality. On probing, he said he had a similar episode of syncope couple of months ago. And on asking for family history, he said he had an elder brother who passed away suddenly. His elder brother was like him long ago, few years ago. They attended a function wherein they were all sitting together. Suddenly, the elder brother became unconscious and he passed away and they couldn't revive him. This was the history. So angio was also done for this patient because troponin was elevated. We couldn't leave him as such. Angio showed non-obstructive coronary artery disease. So what are we dealing with? This patient had a Brugada syndrome. I'll show you what a Brugada syndrome is. This patient underwent an ICD implantation and is now doing perfectly okay. This is the Brugada pattern. You can see type 1 Brugada pattern. All these are the QRS complexes of V1. Type 1 Brugada is Brugada syndrome is nothing but a sodium channelopathy, wherein there is a mutation in the sodium channel. Patients have a ST elevation, coved ST elevation in V1, V2, or V3. That is type 1. Saddleback ST elevation in V1, V2 is type 2. And ST elevation of any type less than 2 mm is called type 3. You can look at this ECG again. This patient, look at V1 and V2, had a classical coved ST elevation like this in type 1. So because he has had a family history of sudden cardiac death and this patient also had a syncope, he comes under high risk category and he underwent a ICD implantation. This is the second case. 55-year-old gentleman presented to the emergency with dyspnea. He had no chest pain. This is his ECG. Is it hyperacute MI? What is it? ECG shows sinus rhythm. T waves are tall and peaked. QRS is broad. P wave is slightly broadened. So what is this? This patient had no chest pain, serial ECGs, no evolving changes. Echo showed no wall motion abnormalities whatsoever. Troponin was negative. Creatinine was 2.1 and potassium was 7.2. So this tall tented T is because of hyperkalemia. The T is so sharp and tented, you put your finger on top of the T, it might poke your finger. This is very classical of hyperkalemia, and tall tented T wave is the first change to occur in a patient with hyperkalemia. Look at this ECG for comparison. This patient again has tall T, but is it due to hyperkalemia or is it due to a myocardial infarction? I can show the previous ECG. Look at this T and now look at this T wave. I have taken a T wave from the previous ECG. You can compare the two T waves here. The T wave in the 12-lead ECG has a broad base. It is not that the apex is not that sharp. It's slightly blunt. This is an ischemic T in the 12-lead ECG. But the small picture which I have put here next to the V2 lead is the T. It's very tall. The QRS is wide. So all these point towards hyperkalemia. It's very important to differentiate the hyperacute T of myocardial infarction from the T wave of hyperkalemia. So what happens in hyperkalemia? The initial change that occurs is because of repolarization abnormality, and that is seen as a peak in T wave. Then as the potassium increases further, there is progressive atrial paralysis. P wave starts to widen, PR interval begins to prolong, and then P wave gradually disappears. As the potassium level increases further, patient develops bradyarrhythmias, AV blocks, conduction abnormalities, bundle branch block, and so on. And when the potassium level goes beyond 8.5 or 9, they develop what is called a sine wave pattern. They are prone for asystole, ventricular fibrillation, and the risk of sudden cardiac death is extremely high. So third case, I was in the cath lab doing a procedure. The duty doctor comes to the cath lab with this ECG. 40-year-old male. He says this patient was previously seen by me. He has undergone some stenting several years ago. Now comes with left shoulder pain. This is the ECG. Duty doctor asks me, do I need to give the patient loading dose and do I need to start him on lysis because already there is a case going on here. I said, no, wait, I'll come and see, because the pain which the doctor said was not very, very classical. He presents with a left shoulder pain. When I inquired the patient, this patient had a shoulder pain which has been there for quite some time, for 5-6 days now. Pain aggravates only on lifting the arm. There is no chest pain. The pain is non-exertional. There were no associated symptoms. History is he had old anterior underwent PCI to proximal LAD 2 years ago. Previous ECG showed exactly similar findings. The ECG post PCI to LAD also showed the same ECG finding. There was Q with ST elevation and T inversion and V2 to V4. Echo showed aneurysmal LV apex. This patient was given analgesics, advised to continue routine medications, and also advised to consult orthopedician if shoulder pain persisted. You can look at the two echo pictures here. On the left is the echo image of this patient. You can look at the apex of the left ventricle. The blue arrow shows the aneurysmal LV apex. Normally, the LV apex is bullet shaped. It's blunt at the apex. You can see here how it's aneurysmal. It is because of this aneurysmal segment there is persisting ST elevation and the ECG. So we should not jump into conclusions and thrombolyze or initiate cath lab for this patient, because it is a MI mimic. It is because of LV aneurysm and it's not a true myocardial infarction. It's a last case, 56-year-old postmenopausal female, diabetic, hypertensive, underwent lap cholecystectomy 1 week ago, now presents with left arm pain, palpitation and sweating. This is her ECG. ECG, not very classical. There is some T inversion V2 and V3. QT is grossly prolonged. There are occasional ventricular premature complexes. So this is the echo. You can see here the apical segments of the left ventricle are very much less contracting compared to the basal segments. Basal segments are hypercontractile. Apical septum, LV apex and apical lateral wall are hypokinetic. Repeat ECG after 3 days. QT prolongation has come down. T wave inversion is beginning to settle. Sinus rhythm is restored. Ectopics have gone. Repeat ECG after several months. Normalization of ECG. T waves are normal. QTC is normal. This is a case of stress-induced cardiomyopathy. This post-menopausal women, usually after a stressful event, it could be an emotional stress or physical stress or stress in the form of surgery. It can precipitate cardiomyopathy, where there is apical hypokinesia and basal hypercontractility. Troponin may be elevated. They usually have non-obstructive coronaries. Supportive care is the recommendation, and long-term prognosis is generally good. So we saw 4 different cases. One is Stachycardic cardiomyopathy. One, we saw Brugada syndrome. We saw a patient with hyperkalemia, and then we also saw a patient with aneurysm. So it is extremely important that we look into the history, look at the old ECGs, keep repeating the ECGs, take serial ECGs. By doing so, we'll be able to differentiate a true MI from an MI mimic. And by doing so, we'll be able to save our resources and institute the appropriate therapy for the appropriate patient and do the best for the patient. With this, I'll close my session and thank everyone for patient listening.
Thank you very much, sir. You have clearly elucidated the importance of doing serial ECGs, because many a times when the first ECG is normal, the patient is usually sent back home. So the importance of good clinical history, importance of past history, looking at previous ECGs, and then taking serial ECGs, and then adjunctive use of cardiac biomarkers and echo. All that is important to differentiate true myocardial infarction from the mimics. So moving on to the next talk by Dr. N. Syed Mohammad Buhari, who's finished MD Critical Care from WIMS Salem, a medalist, and MRCM from the Royal College of Emergency Medicine, London, a lead consultant in critical care services, Sri Kumaran Hospital, Tirupur. So he will be talking on toxidrome. I welcome you, sir.
Thank you, ma'am. Good evening, one and all. I think without much ado, I think it's already running late. I thank IMA, AMS, hope my slides are visible.
Yes, sir.
So at the outset, I'd like to thank IMA AMS West Zone, Coimbatore IMA, state and national leaders of IMA. Welcome you all for this meeting. As running out of time, we'll directly go to the topic. So my topic will be on toxin syndrome. I think most of us are aware of this. You have heard very classical signs and symptoms during our undergraduation, and very important to know about certain common toxin syndromes whenever we are in doubt when we deal with certain poison patients. I start in the name of Almighty God. I pray God to make this session beneficial for all of us and the mankind at large. So I'll be covering this topic about the significance of toxin syndrome, the crux toxin syndromes, and the some case-based scenarios. I think many of us do remember this blind as a bat, dry as a bone, mad as a hatter, and red as a beet. I think I am very much reminded about my off-third professor, Dr. Vijayaraghavan, who taught about this during third year. So this is classically heard toxin syndromes. So basically, what is toxin syndrome? So it is the toxic syndromes or the toxin syndromes. So when we get some patients with poisons, there are some consistent groups of signs and symptoms that are present in those patients, which are called toxin syndromes. They may be classic or complete, like I said for the previous slide, which is very classic of datura or anticholinergic poisoning. Sometimes we may get only partial signs. So before I move into the actual toxin syndromes, let me tell about the significance of this. So it may help us in delineating diagnosis. So when we get a poisoned patient, there will be three basic scenarios. One thing is patient has consumed some poison and patient has got signs and symptoms. So it is easy, but we will be little bit doubtful about if they have consumed the toxic dose, which will cause their endanger to the body. The next condition, patient will have signs and symptoms of toxin and the patient will be very sick, where we should be treating the patient rather than finding out the cause. So we should stabilize the patient, then go for the exact diagnosis. The next thing will be the very important part where we don't have a proper clue. Patient will have some signs and symptoms which is directing towards a poison, but still we don't have appropriate clues. So in those cases, toxin syndromes might help us. So when we know the set of examination findings and history that are consistent with certain poisons, then we may delineate our diagnosis, then we can understand severity in certain cases, and we can go ahead with antidote administration, and we can formulate assessment, and we may also get fascinating combinations sometimes. As I said, sometimes it may be partial. We may not get all the findings of the toxin syndromes, but few things may help us to form the diagnosis and go ahead with treatment. So this is one of the fascinating case which we saw. This gentleman was a 54-year-old man who was received with ventilator support after being treated for fever and altered sensorium. He was having a diagnosis of meningitis. He was treated in a nearby city and he came down to a hospital because of affordability issues. He was related to our MD. So he came to our hospital basically for supportive care, but he had this pinpoint pupils. But we were really not surprised because I think the previous hospital has done enough investigations to rule out organophosphorus poisoning, because they have done Wright's tube, they have done gastric lavage, but they couldn't get any smell or any doubtful substances from the lavage. So even they have ruled out this. Only then they have formed the diagnosis of this AMSAN, which is acute motor sensory axonal neuropathy. So we were also a little reluctant initially for first 2 days. We were just thinking that this pinpoint pupils was correlating only with this brain issues, like meningitis or so. But third day also, we had seen some fasciculations on his side. So we just did a serum cholinesterase. So this is not something new. We do see patients who come in altered sensorium and we suspect poisoning in them because of this pinpoint pupils and other set of toxic syndromes. We do a lavage, we get some smell, we get some agent, and we do cholinesterase, and we have treated and we have sent them home very safely. But this case was totally different because it was assessed in another hospital, formed a diagnosis, and then came to us. They have suspected a poisoning and they have not found anything very abnormal. So this case, after knowing that serum cholinesterase was low, then we had given, we suspected this and we have given him the pralidoxime, after which he remarkably improved. And even after extubation, he had these fasciculations of the tongue, very typical of OPC poisoning. What we were really surprised is that there was no smell, there was no type of ingestion in this. And then we got the history. This is like, you can see, he was completely recovered after treating for the OPC poisoning with pralidoxime and atropine. So this was very interesting that the history then really revealed. This patient said that his wife, who was recently married, she had homicidally given injected OPC poison. She has taken insecticide through syringe. He is a diabetic and she has done injection of OPC. That is why we couldn't get any smell of this poison. So even in these cases where we have doubt, we have partial toxin syndromes, we should be very careful. I think this is the third type, and we should be continuously monitoring the patient and have a suspicion. So whenever we have a suspicion, we should correlate with ECG and other blood tests to delineate diagnosis and try to save the patient. So basically, the principle behind the toxin syndrome is usually this agent which enters the body will cause some vital signs alteration and will cause some clinical manifestations of end organ dysfunction, which we can pick up from history and also examination. So always treat the patient before treating the poison. So together with the history and clinical examination, the ECG plus few blood values will help us to delineate the diagnosis. So the thorough history is very important. The circumstance from where it has happened, was the patient having any comorbidities, what was the occupation, and recent prescriptions, all should be thoroughly received from the patient so that it will help us to form the proper set of toxin syndromes for the patient. So the clinical examination will help us to know about the classical order. Like I said, in our patient, the order was missing, but there are other signs. So always we cannot be sure about classic set being present in any patient. So we should always look for any supportive issues that can really help us to delineate the diagnosis. And also color, on the injection site, temperature. There are a lot of poisons that alter the temperature. You can even have choleriform syndrome, like in colchicine poisoning, like it may be presenting like cholera, diarrhea, gastroenteritis, and so on. So we should also look at alterations in respiratory system. Patient may be having metabolic acidosis and Kussmaul's breathing, and also alterations in blood pressure and pulse rate, like hypotension, tachycardia, bradycardia, based on the agent involved. And pupillary variations, very classic, miosis or mydriosis, alterations in GCS, seizures, and also hypotonia or hypertonia based on the agent involved. So when we can look this in detail when we deal with the specific toxin syndrome. So this is one of the patient which we received after lip suturing in outside clinic. She had an altered sensorium. So this was very classic, and she had a tongue bite. So this was because of the absorption of the local anesthetic systemically. So she had a seizure, and it was proven by a EEG record. So always the circumstance and history is very, very important. So we can get a straightforward color change like this. In this patient, you can see his innerwear getting a yellow color, typical of Sani powder poisoning or Oramin O poisoning. So very classic. So we can see this patient where the patient's attenders were very much particular that the patient has consumed poisoning. They have seen that she was depressed and there were naphthalene balls in her bed, but the patient denied that she has taken it. So in such cases, we will have other symptoms, other signs. So we have examined her urine color, which had a hemoglobinuria. There was hemolysis and hematuria, which was very classical of naphthalene poisoning. And we can also, sometimes there'll be no flow in the history. So this lady was a 60-year-old female. She was a known bronchial asthma patient. She was admitted with altered sensorium. When we did a ABG, it showed a respiratory cirrhosis. So we had to intubate her and just treat her like a acute bronchial asthma. Then just putting the rice tube inside, we could take out her gastric aneurysm. We saw that it was fully yellowish, very typical of sani powder poisoning. Then we asked the attenders, then they were able to admit that she did consume sani powder before coming to the hospital. So it was the allergy to sani powder which caused acute exacerbation of bronchial asthma, and then she went into CO2 narcosis. So the circumstance behind the poisoning is very important in the history. Thorough clinical examination, serial clinical examination is very, very important. We should have a suspicion when the patient doesn't present in a normal mode. So the main tox syndromes are all under these categories, which we'll be discussing further. So the first and foremost is the myorelaxation syndrome. So you have a deep coma. So there is a neurorelaxation. Patient will have hypotonia and hyporeflexiveness, hypotension, and respiratory pressure. The culprit agents are mainly the neurodepressants, the benzodiazepines, barbiturates, zolpidem, a very common agent in day-to-day practice. So these agents, the antidote for this is mostly flumazenil, which is a benzodiazepine receptor antagonist. The only problem is we should not try flumazenil in patients who have seizures. So when the patient doesn't present the seizures, when we have a doubt, when the patient goes for respiratory depression, before trying an intubation, you can always give a dose of flumazenil 0.3 milligram up to 2 milligram. If it's going to be these agents, definitely the patient will improve. Patient may be avoided of the intubation. The next set of symptoms is the anticholinergic, so which we saw in the beginning, the dry as a bone, blind as a bat, and red as a beet. So usually the anticholinergic tox syndromes of three issues. One thing is the encephalopathy. There will be delirium, seizures, and coma. Patient that is mad as a hen. So there will be confusion. Then there will be anti-muscarinic signs where mydriasis, dilated pupils will be there, delirium will be there, and urinary retention, and there is a dry as a bone. So the patient will be very dry. ECG changes are very important. Even tricyclic antidepressants can also have anticholinergic issues. So usually when the QRS duration is more than 160 milliseconds in the ECG, they are very much at high risk of seizures, and they will go for ventricular arrhythmias very easily. So there may be this type of ECG when we deal with anticholinergic issues. So the culprit agents are usually the TCAs, neuroleptics, and datura, and also anti-Parkinson's, which are also causing this anticholinergics. So next is the opioid, where the patient will have this triad of deep coma, meiosis, and brady or apnea. Usually there is a paradoxical bradycardia. Usually in hypotension we get tachycardia, which is reflexive. But in this these patients, because of the central depression, there will be bradycardia with hypotension. So we know the antidote for this is naloxone, which is 0.1 milligram to 0.2 milligram step. The cholinergic, the classical tox syndromes are this sludge, dumbbells, and triple Bs. So which is classical of OPC poisoning. So there will be muscarinic symptoms like bradycardia, meiosis, and increased secretions, or nicotinic symptoms like fasciculation, paralysis, or anti-muscarinic symptoms. Sometimes patient may even present with tachycardia when the nicotinic predominance is there. There is also possibility of central involvement like confusion, ataxia, seizure, and vasomotor disturbances. We know the antidote is atropine and also the pralidoxime and oximes. So this is the classical fasciculations observed in a patient during ECG of OPC poisoning. So the next thing is the adrenergic. We have autonomic disturbances, cardiac disturbances, and ECG changes and metabolic changes. The main culprits are cocaine, amphetamines, LSD, ephedrine, caffeine, and theophylline. The treatment for this will be definitely beta alpha blockers. When we are dealing with cocaine, we should be very careful. We should not give pure alpha or beta blockers because it may be causing severe vasospasm enough to cause a MI or a stroke. So serotonergic, very common, but due to drug interactions, So we can get neurological, autonomic, or biological issues from serotonergic reactions, and it may be because of SSRIs or monoamine oxidase inhibitors and lithium and L-tryptophan. So malignant neuroleptics, when we use older neuroleptics like chlorpromazines, we can also get a very high temperature like hyperthermia, which will not respond to paracetamol or any treatment. They will need myorelaxation. So confusion, generalized hypotonia, axial rigidity of muscles, hemodynamic instability, and rhabdomyolysis may result from malignant neuroleptic syndrome. The culprit agents are the older neuroleptics and the dopamine agonists. So the membrane stabilizing agents, especially the cardiovascular, neurological, respiratory, and metabolic causes will be there. So we can have the flattening of T wave, prolongation of QT interval, and widening of Kuros complex, and even Brugada patterns may be there in membrane stabilizing agents. So the culprit agents are class 1 antiarrhythmic drugs. The classic occurrence is because of the local anesthetic getting into systemic absorption, which is the lignocaine. So which we saw in the previous example where the patient got seizures. They may also get a wide QRS issue when the systemic absorption is there. Other agents are TCAs, antiepileptics, carbamazepine, analgesics, and illicit drugs. So this is one case where a patient was sutured outside with local anesthetic lignocaine, and it got systemic absorption and presented in altered sensorium. So in ECG, we were able to see some rhythm abnormalities, and the patient had tongue bite. So this is because of lignocaine toxicity. There were ECG changes and seizures. So AVG is a very important toxidrome to diagnose a lot of toxins. So there will be classic high anion gap metabolic acidosis along with neurosensory disturbance in causing hyperthermia and dehydration. So those aspirin and derivatives will cause neurosensory disturbance along with hyperthermia. In when the high anion gap metabolic acidosis is associated with osmolar gap and visual disturbance, the agents involved will be methanol. So which we recently saw in Tamil Nadu, a lot of patients getting methanol poisoning. And we may also get other agents causing high anion gap metabolic acidosis like metformin, cardiotoxic agents, paracetamol, cyanide, theophylline and propylene glycol, and also carbon monoxide poisoning. In carbon monoxide poisoning, we usually have a very pink color of the skin, very classical. And also when we deal with even cyanide poisoning also, patient will have a very pink color. So this is also very classical toxindrome. So another very important toxindrome is the saturation gap. So here we had a patient who consumed actually the growth promoter. So it was a plant growth promoter poisoning. So the saturation in the monitor was only 89%. Even giving 15 liters oxygen did not improve the saturation. But when we took an ABG, the saturation was around 99%. So the saturation gap means the gap between the arterial saturation and the saturation in the probe. When the saturation gap is more than 10%, it means that there is some abnormal hemoglobin in the body, which is catching hold of oxygen, but it is not giving to the tissues. So there is oxygen in the hemoglobin, but it is not delivered. There's a shift of hemoglobin, hemoglobin dissociation curve towards the left. So in such cases, we should always suspect methemoglobinemia or carboxyhemoglobinemia. So in this case, it was the methemoglobinemia. You can see the arterial blood color, which is chocolate brown. You can see on the left side of the screen. The right side is from a normal patient's arterial blood. So this chocolate brown color is very classical of methemoglobinemia. So this patient actually was a plant growth promoter poisoning. Usually, though it is a growth promoter, this growth promoter is prepared with nitrobenzene solvents. So the nitrate compounds usually cause methemoglobinemia. So we should be very careful when we get a saturation, low saturation in the probe, and you do a ABG. If there's a gap, always suspect methemoglobinemia. Take a ABG, just the color of the blood will tell you the diagnosis. So the next final agent are the hypoglycemics. So any agent that causes hypoglycemia will cause altered mental status, autonomic disturbance like sweating, tachycardia, and at extremes, they may cause seizures. So thank you for patient listening.
Thank you, Dr. Syed Buhari. And for an excellent talk and almost a new, different topic. And it was wonderful, almost, because we are in the fag end of the program. I'm sorry, we have pulled you to the last, and happy to see that almost we have got 165 delegates still remaining online.
165, 165.
165 delegates are there, so don't be worried that you're the last speaker. Still, we have got a lot of all the delegates. I think, probably, your informations were very quite clear. Probably that we're not having much questions on the last session, and a lot of you clearly put all the details when you suspect. Probably, this will make everyone to think, especially we are not working in an emergency setup. I think you have all cases where only emergency setup. Probably, this will give a clue to the general physician who's attending the patient first, and to refer and make a diagnosis and get the specialist opinion. And thanks, Syed Buhari. Excellent. All the speakers and all the chairpersons have done well, very well. And now probably I'll call upon our secretary, Dr. Jalil Ahmed sir, who is very, very.
Sir, humble request for the last speaker.
Yes, sir.
Yes.
What are the challenges you face?
Sir, we have a
Sir, yes, sir.
Please allow the question. Please allow the question, sir.
Yes, sir. Yes, sir. Can I please pardon?
No. Question is Syed Buhari. Question is, what are the challenges you face? All you have said, you explained.
Yes.
The challenges,
Yes,
all you have explained. Already been explained by the speaker, sir. The challenges. What are all the challenges?
Only the abstract we want. Abstract only I want.
Yes, sir. The most challenging case was the one case which I put in the beginning.
It's not. Just give some, take home message or not to take home message. That's what he wants.
Exactly for family physician.
Take home message, 2 points.
Okay, sir. So whenever we get even one suspicious clinical sign, like a pinpoint pupil, it may be a tachycardia, when it is not correlating with patient's presentation, and when the patient presents with altered sensorium, the thorough history and clinical examination is always important. And if at all you admit the patient with a suspicion of poisoning, you should go for serial clinical examinations. We should always revise your diagnosis. So when the classical presentations are easy to just pick up and give an antidote. The tough ones are the one which doesn't give any clue. So those patients we can only pick up with thorough clinical examination, thorough history, and serial clinical examinations, and always get the circumstance behind where the poison has occurred. Sometimes patient would have consumed 2 agents or more. So we will be thinking that patient has consumed, like I said, there are a lot of cases where doctors have asked me, like patient has present OPC, but the patient has tachycardia. So few agents will have nicotinic predominance. So it's always a circumstance and thorough history and clinical examination and the suspicion. I think we should have a suspicion like a policeman. So when we deal with poison.
Thank you, Dr.
Thank you, sir.
Syed
Thank
Buhari and Dr. Ranganathan. Syed Buhari, you really said that, whatever the AA comes or not, the history taking still remains, and good clinical examination, it has got a definite say. It cannot be replaced by an AI. Okay.
Yes.
Thank you, Dr. Buhari, and over to Dr. Jalil sir for giving the vote of thanks.
Thank you, Chairman. So we had a wonderful session today, the part of IMA Coimbatore Branch. Before I give the vote of thanks, I put it on record. This is 220 registered participants. Until now, it is 165 they are listening. So that's a great effort of our chairman, Dr. Balamurugan. And thank you, sir. So, dear esteemed senior members of this forum, colleagues and my dear friends, good evening. On behalf of IMA Coimbatore and IMS Wing, I extend my heartfelt gratitude to our esteemed President, Dr. Priya Kartik Prabhu, Secretary Dr. C. Ramalingam, and Finance Secretary Dr. Parameswaran for their unwavering support and allowing AMS wing of IMA Coimbatore to conduct this program. We are also immensely grateful to our state AMS chairman, Dr. Rajesh Babu sir, and state secretary, Dr. Jayaraman, for their contribution to this forum. The branch AMS chairman, Dr. Balamurugan, we should thank him for choosing the best of the best, the speakers from all the West Zone, like Erode, Salem, Tirupur, Pollachi. He has equally distributed the specialist of the specialists, and we are benefited by your talk. Our immense thanks to our beloved President Dr. Abul Hassan for his inaugural address and his excellent talk on professional excellence, the way forward. Actually, I suggested this talk because having listened to him so many occasions, he has given the very insightful messages to the younger generation. Thank you, sir, for inspiring your valuable time in spite of our busy schedule. We also thank our State Secretary, Dr. Karthik Prabhu, for his initial remark. A special thanks to all the speakers and chairperson, like the speakers, Dr. Neminathan, the chairperson, Dr. Dorekannan, the Vengo Bharat, then Madam Bavadarani Madam, and Abul Hassan sir.
Thanks to Sengotian sir, President-elect also.
President-elect Dr. Sengotu and Dr. Ranganathan, my own colleague Dr. Syed Mohammed Bukhari for his excellent talks on toxidrome. Very good presentation. And the chairperson Usha, all the speakers, they have given a very insightful, the updated messages they have given, and we will honored to listen to you, madam, and all the speakers. Thanks on the behalf of AMS IMA Coimbatore chapter. We extend our gratitude to all the IMA members and medical professionals who took time out of their busy schedule to attend this event online, demonstrating their commitment to continuous learning and professional development. Once again, let me thank all of you for your contribution.
Technical team also, sir. The technical team and
I am coming, chairperson. Chairperson is always pushing me to execute all the works. All these 10 months we are very busy, and I know that without the IT person, especially Vijay Kumar and Prabha, we have done the best of the best job. Thank you, IT personnel and madam, and all those. I really enjoyed because there is no special mention. All the 8 speakers, they have done wonderful, and we will continue to do our academic work. And I wish all the IMA members to become the AMS members. And our chairman constantly insisting to become the AMS member, and it is very useful. Only the specialty people can join, and we listen to one another. Thank you very much. Have a great day. Thank you, sir.
Sir, thank you all. Thank you, sir.